Respected Chief Guest for the event, Professor Dr. S.M. Bandekar Sir, Organizing Patron, OTCon, Dean and HOD of Department of Orthopedics, Goa Medical College, Goa. Kindly welcome, sir. Thank you, sir. Thank you, sir. Our special guest, Professor Dr. Sandeep Sardesai Sir, Director Academics and HOD of Department of Physiology, Goa Medical College. Thank you, sir. Our special guest, Professor Dr. Vaishali Joshi Ma'am, HOD of Department of Pediatrics, Goa Medical College. Thank you, ma'am. Thank you, ma'am. Our resource person for the event, respected Dr. Teresa May Benson Ma'am, owner and president of TMB Educational Enterprises. Welcome, ma'am. Thank you, ma'am. Our Honorable President of IOTA, Organizing and Chairman of OTCon 2025, Dr. Pankaj Bajpai, sir. Thank you, sir. Respected Dr. Joseph Sunny, sir, Secretary of IOTA. Thank you, sir. Respected Dr. Jyotika Bijlani, ma'am, Dean, Academic Council of Occupation Therapy, Coordinator, OTCon 2025. Thank you, ma'am. Respected Dr. Vivek P. Vajratkar, sir, Organizing Secretary, OTCon 2025. Respected Dr. U. Ganapati Shankar, sir, Chairman, Scientific Program Committee, OTCon 2025. Professional, experts and delegates to the inaugural event of pre-conference workshop titled on Clinical Assessment and Intervention for Praxis in the School Environment. It is my distinct pleasure to invite the guiding force behind this event. Sir has been instrumental in shaping scientific discourse and fostering knowledge exchange. With his unwavering dedication and vast expertise, he continues to inspire professional and researchers alike. May I now invite our scientific program chairperson, Dr. U. Ganapati Shankar, sir, to deliver the welcome address.
Good morning to everyone. First of all, I would like to welcome our honorable, our most respected president of IOTA, Dr. Pankaj Bajpai sir, and honorary secretary, Dr. Joseph Sunny sir, Dean Accord, Dr. Jyotika Bijlani madam. Thank you, sir. Thank you, President sir, to grant permission to organize this international level pre-conference workshop during OT ICON 2025. In IOTA history, this is the first time we are organizing pre-conference workshop during our IOTA conference. Thank you for accepting our invitation to inaugurate this one-day workshop during your busy schedule. It is a great honor to welcome you on behalf of Organizing Committee of OT ICON 2025. I welcome you. I would like to welcome our most respected, Honorable Dean Medical, Head of the Department of Orthopedics, Goa Medical College. Thank you, sir, for all your support, encouragement, and motivation, and grant permission to organize this international level pre-conference workshop at Goa Medical College, Goa. Thank you, sir, for accepting our invitation to deliver chief guest address for these special occasions. It is my privilege to welcome you on behalf of Organizing Committee of OT Icon 2025. I welcome you, sir. I extend my sincere welcome to our special guest, Dr. Sandeep, sir, Director Academics, Head of the Department of Physiology, Goa Medical College, Goa, and Dr. Vaishali Joshi, Madam, Head of the Department of Pediatrics, Goa Medical College. On behalf of Organizing Committee of OT Icon 2025, I welcome you, ma'am, sir. I welcome our most respected resource person, Dr. May Benson, Madam. She is the owner and president of TMB Education Enterprises, USA. She is a well-known academician, researcher, and clinician in the field of sensory integration therapy, theory, as well as intervention. She has authored numerous books as well as chapters. She published various research articles related to sensory integration, intervention theory, as well as published more articles for developing various assessment tools, especially Praxis, gravitational insecurity in USA context. She completed her doctoral dissertation on ideational praxis. She has a diverse background as a clinical practitioner. She worked in private and public school setting as well as private practice. She is actively conducting research related to sensory integration through non-profit organization of Spiral Foundation Sensory Integration Research Center. Thank you, ma'am, for accepting our invitation to share your expertise to our Indian occupational therapists. I very well known about ma'am from 2003. She is good of one of my good friend. Thank you, ma'am. It is a great honor to welcome you on behalf of the Organizing Committee of OT Icon 2025. I welcome you, ma'am. On behalf of Organizing Committee, I would like to welcome our IOTA Vice President and Treasurer and Executive Committee members for this international level workshop inaugural program. I would like to extend my warm welcome to all delegates for this workshop. So, I would like to explain about the background of this workshop. When I was selected as a scientific committee chairperson, so I got discussed with our organizing secretary to organize pre-conference workshop, because the international national level conference they are organizing pre-conference workshop to update their knowledge in hands-on training. So without any hesitation, our organizing secretary immediately accept my proposal. Our both intention is to improve evidence-based practice among Indian occupational therapists through the pre-conference workshop. So I appreciate his effort to overcome many hurdles to organize this pre-conference workshop. We choose this topic, clinical assessment and intervention for praxis in the school environment. The reason behind this, now many occupational therapists in India, they are working in school environment. So especially in learning disability. So these children have problem in the praxis. So due to that, their performance in academics, play, and social participation affected. So most of the occupational therapists struggling for assessment and intervention in the school-based environment. So our resource person, May Benson, is a more competent in the school-based assessment and intervention, especially on praxis. She developed her own assessment tool they establish validity also. That's why we invited the competent resource person on this particular topic. So I request all the participant delegates utilize this rare opportunity to update your theoretical as well as the practical skills in praxis assessment and intervention in school-based environment. I wish you all the best. Thank you, one and all.
Thank you, sir, for your insightful perspective on this event, coupled with your leadership and untiring commitment to advancing our field. Thank you, sir, for your words of wisdom. Light symbolizes abundance, prosperity, and knowledge. In the glow of this ceremonial lamp, let knowledge shine bright, peace prevail, and prosperity flows into our life. May I now request all the dignitaries on the dais to join for lighting the ceremonial lamp.
तुषारहारधवला या शुभ्रवस्त्रामृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनी वीणा पुस्तकधारिणी अभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधती पद्मासने संस्थिता वन्दे तां परमेश्वरी भगवती बुद्धिप्रदां शारदा बुद्धिप्रदां शारदा बुद्धिप्रदां शारदा.
Thank you, dignitaries. I would like to invite Dr. U. Ganapati Shankar Sir, Chairperson, Scientific Program Committee, to felicitate our Honorable President of IOTA, Dr. Pankaj Bajpai Sir, with a bouquet. Thank you, sir. I would like to invite respected Dr. Vivek P. Vajratkar Sir, Organizing Secretary, OTCon 2025, to felicitate our respected Secretary of IOTA, Dr. Joseph Sunny Sir, with a bouquet. Thank you, sir. Okay. I would like to invite Dr. U. Ganapati Shankar Sir to felicitate our respected Dr. Jyotika Bijlani Ma'am, Dean, Academic Council of OT, Coordinator, OTCon 2025, with a bouquet. Thank you, sir. I would like to invite Honorable President of IOTA, Dr. Pankaj Bajpai Sir, to felicitate our Chief Guest, Professor Dr. S.M. Bandekar Sir, Dean and HOD of Department of Orthopedic, Goa Medical College, with a bouquet. Thank you, sir. I would like to invite our respected Dr. Joseph Sunny Sir, Secretary of IOTA, to felicitate our Chief Guest, Special Guest, Professor Dr. Sandeep Sardesai Sir, Director Academics and HOD of Department of Physiology, Goa Medical College, with a bouquet. Thank you, sir. I would like to invite Dr. Jyotika Bijlani ma'am, Dean, Academic Council of Occupation Therapy, to felicitate our special guest, Professor Dr. Vaishali Joshi ma'am, HOD of Department of Pediatrics, Goa Medical College, with a bouquet. Now I would like to invite our chief guest, Professor Dr. S.M. Bandekar sir, Dean and HOD of Department of Orthopedics, Goa Medical College, to felicitate our resource person for this event, Dr. Teresa May Benson ma'am, with a bouquet and a memento. Thank you, sir. We are truly privileged to have with us Dr. Pankaj Bajpai sir, the President of All Indian Occupation Therapist Association. Sir has been a leader in the field of occupation therapy, consistently contributing to the growth and development of the profession. Sir's tireless effort in advancing the standards of occupation therapy across the country have made a lasting impact. Now I humbly request Dr. Pankaj Bajpai sir to deliver the inaugural address for this event.
Respected dignitaries on the dais, esteemed resource person Dr. Teresa A. May Benson, distinguished guests and dear occupational therapy professionals, a very good morning to all of you. It is my privilege to address you all at this pre-conference workshop. It is an important initiative that brings together professionals dedicated to advancing occupational therapy practice. The workshop focusing on clinical assessment and practical intervention for Praxis is particularly significant as it equips us with the knowledge and tools to support children in translating their ideas into purposeful actions within the school environment. I extend my heartfelt appreciation to our esteemed resource person, Dr. Teresa A. May Benson, for graciously sharing her expertise with us. Her contributions to Praxis intervention are invaluable, and I am certain that her insights will immensely benefit our practice. I also commend the Goa branch of All India Occupational Therapy Association for their initiative, especially Dr. Vivek Vajradkar, in organizing this workshop in collaboration with AIOTA. The overwhelming response with 139 participants registering is a testament to the growing interest and commitment within our community. I am pleased to note that this workshop includes both theoretical and practical sessions, ensuring a well-rounded learning experience. Additionally, the inclusion of online participation for some sessions extends the reach of this valuable knowledge beyond physical boundaries, making it accessible to a wider audience. I extend my gratitude to the executive body of All India Occupational Therapy Association and Academic Council of Occupational Therapy, especially Dr. Jyotika Bijlani, as a team for their presence and support in strengthening such academic endeavors. As we engage in discussions and hands-on learning today, I am confident that this workshop will enhance the clinical expertise of the OTs and contribute meaningfully to their professional growth. Let us make the most of this opportunity to learn, collaborate, and advance the practice of occupational therapy for the betterment of the individuals we serve. Wishing you all an enriching and productive session. Thank you very much.
I extend a heartfelt gratitude, sir. Sir, your words have not only set a positive and motivating tone for the workshop, but have also provided valuable insight into the future direction of our field. Thank you, sir, for delivering such an inspiring and thought-provoking inaugural address. It gives me immense pleasure to invite our esteemed chief guest for the session, Professor Dr. S.M. Bandekar, sir, organizing patron of OTCon 2025, Dean and HOD of Department of Orthopedics, Goa Medical College, Goa. Sir's contribution to the medical community, particularly in the realm of orthopedics, is unparalleled. Under his leadership, the department has thrived and his dedication to advancing healthcare and education has set new benchmarks for the profession. We are privileged to have Sir with us, and I now request Sir to deliver the chief guest address for this event.
A very good morning to all of you. This is not my original voice, so please excuse me. Madam Bijlani knows my voice, it is better than Kishore Kumar. Country President, Dr. Pankaj, Country's Secretary, Dr. Joseph, today's faculty for workshop, Madam Teresa, my professors, Dr. Sandeep, Dr. Vaishali, then we have the scientific chairperson, my own occupational therapist, Dr. Vivek Vajratkar. I call him Dynamo of our occupational therapy department. And one day he came to me and said, "Sir, we want to organize the national conference in Goa Medical College." I said, "Who has stopped you?" And he came out with such a wonderful program, and it went so seamlessly. And today is the day that I have a proud privilege to host all of you, such a wonderful young occupational therapist in my institute. For the Madam Teresa, this is the oldest institute in Asia, which was established by then Portuguese in 1848. And those days we were issuing the School of Medicine degree. And people who studied here, they had a fantastic basic knowledge of medicine, of almost all common diseases. And their bedside practice was fantastic. A general practitioner would do lumbar puncture without any trial and error. And this is basically because the bedside practice in those days was really rigorous. I am happy to know that occupational therapy national and international conference is for the first time is having a pre-conference workshop. The workshops are needed basically to train your hands, to give you skills. And it is a big, it is a big layer of treatment. When I was a professor, I became a professor somewhere in 2004. And in 2013, I started a college of occupational therapists in this very institute. And to start with, we had only 10 seats. And today it has grown to 22 seats. I am happy because especially a person like me who's doing a lot of reconstructive surgeries in trauma, I need a person who will rehab my patients. And this occupational therapist who work with me, they are doing such a fantastic job that the patient who had suddenly got into massive disability comes out with zero disability. This is an achievement. And I always tell Dr. Vivek that you have added a very, very important step in the treatment of rehabilitation. We have to see that country like India, we have a lot of patients who fall from height, who get spinal injuries. There are patients who get spinal infections. And when they go home, there is nobody to look after them. I had my own experience as a resident. Those days we used to get a lot of people falling from coconut tree, which is a common profession in Goa. I don't know, must be in Kerala also. because when they go for a toddy tapping, you know what is toddy tapping? It's one of the, profession where you get the toddy from the coconut, come down, sometimes it gets fermented and they also are tempted to drink. When they drink, they get alcohol effect and then they fall also from the tree. This used to happen very common in Goa, and we used to treat these patients. After treating them, some of them had residual paralysis, some of them had paraplegia, quadriplegia, and we used to send them back home. I had once or twice an opportunity to visit this house, these people. That is what is the rural Goa. I went to Pernem, which is a remote village in Goa, and I saw this man, after he was discharged, nobody had changed his dressings of bed sores. Nobody had given him passive range of motion for his joints. Nobody had cared for his bladder, and nobody had cared for his bowel. His quality of life was so poor. And that is the time we decided, and we are also proposed to the government. Now every primary health center will have occupational therapy and a physiotherapist. This is going to improve the health and the rehabilitation of most of our patients. I know that this conference has a great scientific program designed by a very person who is here, and you are going to benefit from this. Today's workshop also, there is going to be a lot of exchange of knowledge, and I hope and I wish that this OTCon gets the greatest success for next 3-4 days. Thank you for inviting me here.
I sincerely thank you, sir, for your kind words, and they will be cherished and remembered for a long time, sir. Once again, thank you, sir, for honoring us with your presence and for your significant contribution to the success of this event. Thank you, sir. I would like to invite respected Dr. Vivek P. Vajratkar, sir, Organizing Secretary, OTCon 2025, to deliver the oath of thanks for this wonderful occasion.
Good morning, everyone. Respected Chief Guest, Sir Professor Dr. S.M. Bandekar, Dean Goa Medical College. Guest of Honor, Sir Dr. Pankaj Vajpayee, Sir, President Avoda, Dr. Sandeep Sardesai, Director Academic, Professor and Head Department of Physiology, Dr. Vaishali Joshi, Professor and Head Department of Pediatrics, our resource faculty, Dr. Teresa A. May Benson, Dr. Jyotika Bijlani, Dean Academic Council of Occupational Therapy, Dr. Sani Joseph, Honorary Secretary, Avota, Dr. Ganpati Shankar, Scientific Chairperson, OTCon 2025, and present senior eminent faculty members and the participants. It is my immense pleasure and privilege to extend a heartfelt vote of thanks on behalf of Organizing Committee OTCon 2025 and Goa Medical College. I hope this pre-conference workshop will get you incredible learning experience, in presence of such an eminent resource person in the field of occupational therapy, who will be sharing the knowledge and insight that will undoubtedly have a lasting impact. This marks a historic milestone, as it is the first time pre-conference workshop is being held at the national conference, making it even more special occasion. First and foremost, I would like to express my deepest gratitude to our esteemed resource person, Dr. Teresa A. May Benson from USA. Your expertise, dedication, and insightful presentation will enrich our understanding and invaluable knowledge. A special thank to the scientific chairperson, OTCon 2025, Dr. Ganpati Shankar sir, and Dr. Jyotika Bijlani ma'am, Dean Academic Council of Avata. With their effort and initiation, we could able to organize this workshop. I also thank Sir Dr. Pankaj Vajpayee, President Avata, and the Honorary Secretary, Dr. Sani Joseph, for allowing us to start this initiative wholeheartedly. A big thank to our distinguished guests and dignitaries for gracing this occasion. With your presence, your support and encouragement mean a lot to us and reinforce the importance of such academic and professional gatherings. I would like to extend my sincere appreciation to organizing committee, coordinators and volunteers who have worked tirelessly behind the scene to ensure the smooth execution of this workshop. Your commitment and teamwork have played a crucial role in making this event a seamless experience. This vote of thanks will be incomplete if I don't show appreciation to Sir Dr. S.M. Bandekar, Dean Goa Medical College, and the conference patron. Without his support, we will not able to achieve our vision. Our gratitude also to our sponsorer, platinum sponsorer, Speech Gas Private Limited and RCM Healthcare Services, and other event partners for their generous support and contribution. Last but not, a big thank you to all the participants for enthusiastic engagement and active participation. Your curiosity and eagerness to learn have made this workshop in reality. As we conclude this inauguration, let us carry forward the insight gained and continue to work together toward the advancement in this area of occupational therapy. We look forward to your continued participation in upcoming workshops, sessions and scientific sessions of OTCon 2025. Once again, I thank you all and wishing you a wonderful conference ahead. Thank you.
Thank you for your kind words, sir. May I now request all the dignitaries present here, as well as our audience, to kindly rise for National Anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Thank you, ma'am. Thank you, ma'am. All the support.
Give me a minute, and I'll just introduce and we'll start the session. Okay.
Change over the top.
Good morning, everyone. It is my privilege to extend a warm welcome to all of you for the pre-conference workshop titled on Clinical Assessment and Intervention for Praxis in School Environment. Today we are gathered here for an insightful session focusing on to identify key observation that indicates praxis challenges in children, to describe the role of praxis in developing functional skills critical for school success, to articulate how to apply clinical reasoning for intervention planning to address praxis challenges in the school environment, and to state example intervention activities for the school environment that addresses praxis challenges. Without further delay, I would like to welcome and hand over the stage to our esteemed resource person, Dr. Teresa A. May Benson, ma'am, and begin the first session titled on Introduction to Praxis, Functional Implication of Praxis on Development. Welcome, ma'am.
Thank you very much. Thank you, everybody. Can you hear that okay? All right. Welcome, and I'm very delighted to be here today. Dr. Sankar and I have been friends and colleagues for close to, well, over 20 years now, I think. And I have many Indian students at the US and colleagues in various parts of the world. And so I'm very, very delighted to be here today for the first time. So thank you very much for having me. I'm going to be a little bit relaxed here today. That's sort of my normal style. I have a few praxis challenges of my own to contend with. Usually I have a microphone, on my head, and I can wander around, and they've got me tied to the podium or holding on to a mic. So these are all new praxis challenges for me. So we'll make it work. The other thing, oops, here we go. The other thing you're going to see me do is drink my tea, okay? Because we all have to self-regulate, right? And so my tea is the way that I self-regulate. So you'll see me drinking my tea throughout the day. So we're here to talk about assessment. Hold on. Can we shut this door? Thank you. Background noise, distractibility, modulation problems, right? All right, so we're going to talk about praxis in the school environment. And practicing in the school systems, regardless of where you're at, has its own set of challenges. Some of you may have a clinic space available to you in your school system. Some of you may only be maybe treating in the hallways, right? Or perhaps in a room, maybe an old classroom. Some of you may be doing push-in services in the classrooms themselves. There's such a wide range of service delivery in this particular setting. And I'm going to try and give you some strategies for all of those different settings, okay? And praxis can be tricky to treat effectively in the school system unless you have a clinic space to work in. But I'm going to try my best to give you some strategies and ideas of things to do to support these kids regardless, all right? Now, let me also just orient you a little bit to your handouts. You'll see I gave you a pretty extensive handout list here. If you look towards the back, around page 29, it says appendix materials. So in this section, you have this model of sensory integration that I'm going to go over. So when this comes up on the screen, you'll know that you can find it here. We also have a clinical reasoning model that I'll go over this afternoon. And then the rest of the handout is this clinical observations of sensory integration and praxis. This is an observational assessment tool. And then I'm going to be going over that. And as I go through the information on my slides about the various observations, you'll see that they are not in your notes. There's blank spaces, so you can write, but the actual observations are all here on this document. Okay? So you don't have to write down all of the observations. They're in the document. I just didn't put them in the handout section. Does that make sense? Okay. The other thing I just wanted to say is you are welcome to use this document in your clinical practice. All right. What I ask is that you're here. I'm assuming you paid to attend conference, right? So you bought the test. Okay. Please do not distribute it to other people, all right? It's for your use in your clinical practice. You can share it with others in your clinic if you're working in a clinic. Also, please respect my copyright and don't keep my information on it, okay? So I just ask that. The last thing I've given you in your handouts is for each of the aspects of praxis that we're going to be looking at, I have given you some activity forms. All right, so don't tell me that you didn't get any treatment ideas, okay? There's lots and lots of pages of treatment activities here for you. The majority of these do not require suspended equipment. There are some that do, but most of them do not. So they're hopefully things that you can look at for inspiration to come up with your own ideas for that particular aspect of praxis. Okay? So that's what we've got here. So let's get started. Oops. And hold on. Where's my mouse? There he is. There we go. All right. So just real quick, what are we going to talk about today? I want you to be able to identify some of the key praxis challenges in kiddos. All right, that's one of our big things. Secondly, also, I hope that by the end of today, you'll have a better understanding about how praxis impacts on functional skills. All right. We only have one day. Normally, I do a course like this over 2 days, and I give you a lot more theoretical background to really ground you in this content. Today's information is more the practical information. I also want you to come away with a better idea about clinical reasoning, all right, for your intervention planning, and then to be able to come up with some activities. So let's start off with our introduction to praxis. What I want to do here is to show you part of this video. The whole video is about 20 minutes long, so we're not going to take that long. But I want to give you just a little bit of snippet, and I'm going to skip through a couple of the pieces. This is an evaluation that was done it is an evaluation of a child in a school setting. The clinician does have access to some treatment space in this facility. But I want you to look at this child and tell me, write down, what you see that tells you that this child has some praxis challenges. Okay? So we're going to start there. And then we'll talk about this kiddo as we go along. So this is Ethan. Or Evan, rather. Sorry, Evan.
Can you color inside the circle? Nice. Try to stay in the lines. Listen. Okay, listen. Stop. Listen. You're going to start at the car. Stop in a minute. And you're going to try to start
like this and
on the road. Yes. Nice.
Look at the house.
Okay.
In the car.
Thank you. Okay, now fold the paper. Now, Can you start with the car?
Teachers, please excuse the interruption. I just received a call. There's going to be an interruption on the internet. If you are on the internet, it's going to go down for a little bit. If you are in progress book, please log out now. Thank you.
Nice work. Can you put your name on the line, please?
And shaking. I saw.
Okay, listen. Can you give me just a second? Listen. Okay, let me show you. You're going to start here, and you're going to connect the dots.
And you're
Okay,
going
what
like
shape does it make?
this.
Beautiful. Oh, where's the line? Look for the line first. Can you point to it for me? Nice.
You may
No,
recognize
we're not going
this
to color
as
it.
being
Not
the
right now.
buttocks, the bot.
Okay, we're going to cut it out. Can you stay on the road?
I would.
Can you stay on the road? Go. Can you throw it to me? Can you throw me your phone here? Thank you. Okay, we're going to put it away for now.
I hold it first.
Okay. You can hold it for 1 second, okay?
I don't have it on my back.
Here, let's see if you can dribble. Can you dribble? Okay. Whoa! You want to catch it?
Bounce it. I just am staying.
You want to toss it again? Ready? Oh, can you catch it with one hand? One hand. Can you do one hand? See?
Yes, I got you.
Your turn.
Got it.
Oh! Can you hide a hand?
Yeah.
Hide a hand behind your back.
Yeah.
Look, I'm hiding one. Put an arm behind your back.
Here's this one.
Switch. That's one hand. One hand at a time.
There's more. That's one run. Yeah.
Nice. I think you can get them to fall into the bucket.
Okay. All right, so I think we'll just stop there. I think we can tell that this guy has praxis problems, right? Okay.
Can you color inside the circle?
We're supposed to do that. There we go. All right, so tell me, what did you see that told you that this little guy had praxis problems? All right, what did you see? So, okay, this is going to be interactive. If you just sit there and stare at me all day, we're not going to have any fun, okay? So, sing out, what was an observation that you made that let you know that this child had praxis issues? What did you see? There's lots. Go ahead. Right, so it was hard for him to sit at the chair at the table. All right, he ended up standing for part of the test, right? Yeah. Right, so he's was writing with his left hand, okay, but he was using his right hand for a lot of tasks. Now, I will make a comment. It is very common for lefties to cut with their right hands because the world is right-handed and scissors are right-handed, and having a left-handed husband and a left-handed daughter, okay, they made it very clear to me that usually you cut with your right hand because otherwise the scissors don't work. But you're absolutely right. He did a lot of ball throwing with his right hand. So his laterality and handedness may not be real solid. And by his age, I think this child's about 8. Okay, I said Peter here before I decided to actually use him, but they're basically the same kid. Okay, so he's about 8. All right, great observation. What else did you see? Yes, so there was a lot of distraction with that announcement, okay? And it really was kind of hard for him to come back to task, right? And I feel like after that announcement, I feel like I saw his arousal level kind of go up a little bit.
Hello.
All right, that was harder for him. Okay. Oops. Hello. We have somebody else using a sound. Okay, what else did you see? There's lots. Yeah. Go for it. Right, so he didn't get the boundaries of the shapes that he was drawing. What else? Yeah. Yes, so he did a lot of this, right? Okay, when he was tossing and catching the ball. What did his pencil grip look like? Right, fisted, right, a fisted pencil grip. How much force was he using on that pencil? Yeah, and was his accuracy very good? No. And what about when he put those scissors in his hand? What did he do? Yeah, exactly. So he couldn't orient his scissors very easily, right? And just in general, I mean, when he's doing this, the beads, right? He had to like hold the string down like this and drop it on. So we see a lot of manipulation problems, right? Okay, so although he's not really doing very much with gross motor, all right, we can see the problems with the praxis. Now, how do you think he would look if we took him and we put him in a treatment room? Do you think he would do very well on swings, targeting? No, he's going to have a lot of problems with that, okay? So this is just a couple-minute clip, and we can tell he's got problems with bilateral coordination, he's got problems with motor planning, he's got problems with postural control, all right? We see some arousal and modulation issues, right? All right, so in just a couple moments of just observing this child, it's really testing my sensory. We can really see here these challenges. All right, so that's going to get us started. So now let's just kind of look at this little summary. We see him having problems sitting in the classroom, right? Moving in and out of his seats. Also, we did not see him here having his head on his desk, but what was he doing when he was sitting at the table? What did he do with his arm? He was leaning forward, and so he's propping his body on his arm, right? And leaning on the table. Right, and sitting, now I lost this altogether. Bye. Is it all gone? Can you hear me yet? Is it like actually doing anything? No. Okay. Well, we'll turn that off for the moment. Come on. Down. There we go. Can I try that? There you go. I'll try that for a minute. We'll go back and forth, okay? we see him having problems following directions, right? He really needed like a lot of pointing. Also, did you notice she had to box out where he needed to put his name? Okay. A lot of attending to other things going on around him. And this kiddo had problems completing his homework. So if we look at this kiddo, what do you think was his diagnosis? And why do you think that? What diagnosis do you think he had? What do you think? This is a different kid. It's just a picture. All right, so there's a little guy that we observed, Ethan. He had very high functioning ASD. All right, clearly very high functioning. Learning issues, right? Your basic reading, math, learning disability kinds of things, all right? As well as a lot of sensory integration problems. Now, this is a child that oftentimes is going to be considered to have executive function difficulties, ADHD, all right? And they are often treated only from that perspective. What do you think is really this kiddo's primary problem? It's his praxis and his sensory integration, okay? So we want to be using new eyes when we're looking at these kiddos. Put away those initial thoughts that, oh, well, this is just ADHD, or it's just executive function problems. Yes, you know what? There may be some of that. But we also need to then think, oh, you know what? Maybe there's some sensory processing things going on. Maybe there are some praxis things that are interfering with this child's ability to function in this setting. So, guess what? I ended up using that picture twice. I guess I really like it. This is my son when he was little. He's now 33, so he's all grown up with a little boy of his own. So let's start off with this idea of praxis. All right, so we've been talking about praxis. What is praxis? It's our ability of our brain to conceive of, organize, and carry out a series of unfamiliar actions. So this is important because it tells us that there are different components to this praxis process, all right? We see ideation in terms of being able to conceptualize action, all right? We see organization of action. And under organization of action, we see motor planning. Oops, who did that? I didn't do that. Come back. We see organization of action, okay? Motor planning, bilateral motor coordination, projected action sequences. We also see sequencing problems, okay? And sequencing problems are really an important foundation for praxis. We see the execution and the feedback components, all right? So this is one of the things that makes praxis challenging to evaluate as well as to treat, because it's not one thing. It's not a unitary function. It consists of multiple sub-functions. And so we have to look at all of these various sub-components of the praxis process. And that's why your evaluation form is like 15 pages long. Okay. Next thing then, I want to talk a little bit about terminology. There's this idea of dyspraxia, okay? I tend not to use the term dyspraxia, all right? And here's why. Dyspraxia is, the term means different things to different people. We as occupational therapists who are familiar with sensory integration talk about dyspraxia as being a somatosensory-based motor planning problem, all right? A very specific aspect of sensory integration functioning. On the other hand, if you talk to a neuropsychologist, they will talk about it largely as being a problem of gesture use or imitation of gestures, okay, imitation of movement. So they tend not to acknowledge the sensory foundations to praxis, all right? In addition to that, dyspraxia is not a diagnosis, okay? There's not an official diagnosis of dyspraxia. It's a term that we use kind of as a generic catch-all for children who have motor coordination challenges, okay? So if I use it, I'm going to use it as a generic term of motor coordination challenges in children. I much prefer to talk about children as having praxis challenges or praxis difficulties, and then discussing the specific aspects of praxis that that particular child has problems with. Because not all kids have all problems with all aspects of praxis, okay? The next thing is the term apraxia. And this term refers to adults who have an acquired motor coordination deficit, all right? So they have had typical development through adulthood, into adulthood. Something happened that injured their brain, and now they have problems coordinating their movements, all right? That is quite different from children who never developed the skills in the first place. As we start thinking about this idea of translating research to practice, I think this is an important distinction. We can learn a lot about the practic process from adult apraxia literature, but we have to always keep in mind that we are looking at children who never developed the foundations of praxis in the first place, whereas adults have, and they lost access to that information. So it's really, there are a lot of differences between adults with apraxia and children with dyspraxia, okay? And we need to kind of keep that in mind. In addition to that, we have speech and language pathologists who talk about apraxia of speech. And that's a whole nother ball of wax, because they're talking about difficulties with organization and planning of language, okay, which is, has some relationships to praxis, but there are differences as well. And lastly, we have developmental coordination disorder. Now, developmental coordination disorder is a diagnosis. It's a DSM-5 diagnosis. And this is a coordination disorder. It is a motor impairment that causes functional difficulties, okay? And one of the criteria is that the motor difficulties are greater than would be expected of the cognitive ability. So children with Down syndrome, for instance, who have developmental delays, can have a developmental coordination disorder as long as that motor difficulty is greater than their cognitive level. So say their cognitive level is 8 years old and they're 10. Okay, if their motor level was 8 years old, there would be no DCD. They would just have a developmental delay in motor. Does that make sense? On the other hand, if their motor skills were 6 years old, the motor skill delay is greater than the cognitive delay. All right, does that make sense? Now, it also used to be that you could not have autism and DCD. That has recently changed. So we now are seeing kids getting these dual diagnoses. All right. Many people who live in the, I'm going to call it the DCD world, that don't recognize the sensory contributions to motor. All right, and they think we're all hooey when we talk about somatosensory and vestibular inputs to motor performance. And they feel like children with DCD are a different ball of wax than children with praxis challenges. I'm here to tell you that they're really the same. It's just that they are only looking at children with vestibular-based motor planning motor problems, and we're looking at kids with tactile as well as vestibular, okay? So think about DCD as being kind of a big umbrella that includes our Praxis kids, but can also include other types of motor coordination challenges that are not sensory integration in nature. All right? So does that help clarify a little bit of the terminology business around motor? It's quite messy. All right, let's now also talk about comorbid diagnoses, okay? And I need to move around. I'm going to try this again. Uh-oh. Hello? Can I have my mic? I'm going to be going back and forth. You didn't give me a lavalier mic, so now you're going to have to switch back and forth, okay? Uh-oh. My tech guys aren't keeping up with me. Come on, guys. You can do it. They lost him. Did you turn off my mic? I need to be able to go back and forth here, guys. Work with me. Work with me. Okay?
Hello.
Okay, but in the meantime, can I use this one? Thank you. We're trying. They're trying to get me a collar mic. But can I get this one to work in the interim? It's on, but nobody hears me. No. There you go. Okay, you can hear me now? Okay. Phew. All right. We're trying. So, see, all these Praxis challenges, right? I can't tell if it's working or not. It's not working now, is it? I didn't think so. Can you increase the volume on this puppy? No. Okay. I'm trying, guys. I'm trying. All right, we'll try. I hate podiums. All right, comorbid diagnoses. Kids very rarely just have Praxis problems. All right? We're going to see our overall sensory integration problem. But more often than not, we're going to see learning disabilities. And I know the term learning disabilities means different things in different countries. All right? Is it in this country, because you guys have an English background at some point, right? A lot of English influence. In England, learning disabilities refers to kids with mental delays, mental retardation, cognitive delays. Is that the same here? No? Does it refer to children who have just like math, dyslexia? Okay, that's the American version. Excellent. So learning disabilities, the way I talk about it, is your basic dyslexia, dysgraphia, your math problems, your reading difficulties, okay? These kids who have difficulties with general learning. It may include intellectual disabilities, autism spectrum disorder. Clearly, these kids, 85 to 95% of kids with autism will have Praxis challenges. We also may see problems with mental health disorders like anxiety or depression, and ADHD is often very often comorbid. All right, so we're going to see a lot of dual and triple and quadruple diagnoses in these kids. And one of the things I want to say about that, I frequently have people tell me, well, how do you know what you're seeing isn't the ADHD, the autism, or you name it? What I'm going to tell you is when you see kids like the kiddo we just saw, who has those motor problems, those motor problems are the same, regardless of diagnoses, okay? So one of the things you want to do is really start using your eyes to identify those motor challenges, and hopefully you'll have a better idea. Okay, the next thing I want to talk just a little bit about is sensory integration in general, because people talk a little bit about SI in different ways. There are three major components to sensory integration. We have modulation, which generally impacts our regulation and our behavior, our arousal level. We have sensory discrimination skills, which are the foundation for our body scheme, our spatial awareness, our praxis skills, all right? And then we have praxis, which impacts our skills and our organization. And so we'll be talking about these various areas. So quickly here, I want to talk about modulation and just clarify so we're all on the same page what I'm talking about. Modulation refers to our ability to filter out and evaluate the relevance of a sensory stimuli, okay? So we do two things with the modulation process. We evaluate, and then our nervous systems make a physiological response to that evaluation, okay? So there's a lot of noise going on here, all right? I do pretty well. I'm a pretty well-regulated person generally, unless I'm tired or jet-lagged, like I am now. Well, I'm not so tired, but still a little jet-lagged. And so what happens when your physiological arousal state is maybe not the greatest? It's not 100%. Your sensory threshold levels drop, and more sensory input comes in, so you might be more distracted by that sensory input than you would otherwise be, okay? So you're constantly evaluating the sensory input. I don't know, there's some swishy sound going on back there, right? Okay? And so it's like I'm evaluating that noise, I'm alerting to it, I'm evaluating it and saying, okay, is that something I need to pay attention to? And if I say, no, I don't need to pay attention to it, it's not important, I will raise my sensory threshold levels so that that input no longer comes in, all right, and is processed, unless it changes or I give my attention back to it. On the other hand, if I alert to it and I say, yes, maybe that's something I better pay attention to. Oh no, somebody just yelled out in the hallway. Does that mean there's a problem? So what happens then? My threshold levels drop so I can get more information. Okay, is he going to keep yelling? Do I need to pay attention? And do I need to do anything? Do I need to run out of here because there's a fire? Oh, there he goes again, see? Okay, so I evaluate it, and if I determine that this is important, I'm going to determine, is it positive or negative? Okay? If it's negative, I'm going to go into flight, fright, or fight. This is what happens with a lot of our kids. They are evaluating stimuli as being negative when most of us don't think it's very important. In addition to that, I may evaluate that and say, yeah, it's a negative input, it's irritating, but it's really not important to me. I really need to habituate to it. So I'm going to try and get my threshold levels back up again so I can ignore it. Okay? This is a problem with our kids with modulation problems, is they're not able to habituate to the stimuli. They continue to alert to it. Okay? The other thing I want to point out about modulation is that these are generalized inputs that are processed largely in the subcortical part of the brain. The limbic system, the reticular activating system, okay? And if we have a problem in one sensory system, we very often have problems in another, all right? Because it's a generalized response to the stimuli. Now, with modulation problems, we functionally are going to see issues with arousal, defensiveness, which can result in flight, fright, or fight, distractibility issues, and very often then behavior problems. Okay, thank you. All right, so we're going to try this. Let me turn this one off. There we go. All right. Get that out of the way. All right, okay? So these are the functional outcomes. With discrimination, on the other hand, our discrimination of sensory input tends to be by specific sensory stimuli or multisensory inputs that are coming in together, like vestibular and probe, all right? With discrimination, we are evaluating the salient qualities of the sensory stimuli. So we're going to be looking at spatial and temporal aspects, size, shape, where is it at in my in my body, how fast am I moving my head, what direction am I moving my head, okay? So we're going to be evaluating those specific aspects. Now, discrimination is the foundation of our postural control, ocular motor skills, visual and auditory perceptions. It also forms the foundation for praxis. Now, it also can impact skill and arousal level. So, for instance, if I can't make the microphone work, right, what happens to my arousal? Arousal level goes up. I'm trying to find a coin in my pocket, and I can't find the money. And there's the guy at the store is like getting really impatient because there's 20 other people behind you. What happens to your arousal? It goes up, right? So think about arousal issues in relationship to not just modulation, but also what's going on with discrimination, what's going on with praxis as well. Praxis is probably a bigger contributor to arousal issues than modulation problems, okay? Real important point. Frustration over not knowing what to do, how to do it, making it work, right, guys? These guys know. I'm going to pick on you. I'm sorry, okay? I'm going to tease you all day. Smile, guys, smile. Come on. They're so serious. You can do it. It's all right. There you go. Okay? See, they got frustrated because their stuff wasn't working, right? So the arousal level goes up, and then they go into shutdown. See? So arousal is an important outcome of our praxis. Now, for praxis, we talked about this ability to conceptualize, sequence, okay, organize purposeful actions. Also, being aware here that praxis is often talked about as only occurring with novel or new experiences. And I want to make a point about this, that this is not true. That's a lie. Because tell me, when do you ever do anything exactly the same way twice? Ever? No, right? Because every time you do something, there's always something that's a little different, right? Therefore, everything you do is novel to some degree or another. Therefore, it always takes praxis. The difference is, think about it in terms of how much praxis does it take. Does it take a lot of praxis? Like I'm trying to navigate new microphones, a podium. This is not my usual setup, okay? So I'm doing a lot of praxis planning here today, right? Or does it only take a tiny little bit of praxis because you're doing something that's very well learned and very familiar to you, okay? So start thinking about praxis as being a continuum instead of an all or none type of thing. The last thing I want to say about praxis here is that the most important thing that praxis does for us is it allows us to adaptively interact with our world. And that word adaptively is really important because adaptively is what we as OTs do so well, isn't it? Right? We help people adapt. So what does that mean from a praxis viewpoint? Well, we're going to talk about adaptive responses a little bit later on. But when we're talking about adaptively, we mean that the person is successfully meeting the environmental demand. So as I navigate around here, I'm navigating around these chairs. I'm walking over here. I've got cables on the ground that I have to step over and not trip on and fall on my face. I have to really be aware of the edge of this stage because I'm going to go over the edge of the stage here yet. Wait and see. Okay? So I have to have these spatial considerations that I'm navigating. All right? So as I'm walking back and forth, I have to make sure I don't get too close to the edge because my vision's not that great. I've got like trifocals here. So you know what it's like down here? Any of you wear the glasses? You can't see diddly, right? Okay, so to look down here, it's like depth perception issues. And it's like, oh yeah, step off the edge. Okay? So that's adaptively meeting the needs of the environment. Okay? All right. Next thing. Moving on. Now, when we think about the components of Praxis, this is your summary. All right? We have arousal, rhythmicity, and sequencing are the foundations. These are very much subcortical functions. They are also cerebellar functions. All right, these are the contributors to our cortical praxis. All right, the praxis process itself involves ideation, okay, being able to come up with those ideas. And then notice that I call this second phase of praxis motor organization. Because what are you really doing? You're organizing your motor responses and to specific sensory stimuli. And we do differently based on the characteristics of the sensory stimuli. So why do you think there are like 7 praxis tests on the SIPT or the new EASY? Because every different sensory stimuli, different ways of doing things require different kinds of organization. We've got 2-dimensional for design copying, 3-dimensional for constructional praxis. We have somatosensory inputs for motor planning. We have proprioception and tactile for oral, right? We have vestibular inputs for bilateral motor coordination and projected action sequences, all right? So motor planning, bilateral motor coordination, and projected action sequences are our primary aspects of motor organization and praxis. And they each have different sensory foundations, okay? Then we have feedback, feed forward. These are motor control mechanisms. And then our outcomes of praxis is our organization of behavior and our problem solving. And this is our transition, like this, okay, from praxis to executive functioning. And I'm just going to touch on executive functioning here today because I don't have time to do anything more. But I've got a whole 1-day course on praxis and executive functioning because the research, talk about research to translation to practice. The research today is really talking about the embodied cognition, right? Have you guys heard about embodied cognition? All right, got to read the literature on this. Embodied cognition. This is the concept of cognitive development that is taking the lead today. And essentially the idea behind this is going actually backwards to Piaget. What did Piaget said? He said, cognition develops out of sensory motor experiences, right? And that's what embodied cognition says, is that our cognitive processes develop out of our active motor experiences with the world around us, which is praxis, right? Okay? All right. So this relationship to the development of executive function skills is real important. Yeah. Oh, can I give you an example of it? Let me think about this. Well, yeah. I mean, if you think about infant development, let's think about infant development. So we have our infant sitting there playing with his cups and his little balls, right? And he's putting the ball in the cup, dumping it out, putting it in, taking it out. From a motor perspective, we look at that and we say, oh, he's grasping the ball, he's doing bilateral coordination, he's doing motor planning, right? But cognitively, what is he developing? Form and space perception, size perception, shape, constancy of space and volume, which are all cognitive skills. Okay? Does that make sense? All right? So this idea is real important. So put that on the back burner, okay? Executive function skills, really related to praxis. And maybe we can talk about it in detail another day. Dr. Sankar, right? Talk to him. All right, next thing. I want to take a word about bilateral skills, okay? I'm going to change your thinking on this again. Another new thing to think about. I've been thinking a lot about bilateral coordination skills. I have a colleague who, in the SI world, who is quite adamant that bilateral coordination skills are not praxis. Okay, we have had a lot of arguments about this. And I'm like, buttoning my shirt is praxis, right? And it's a classic bilateral coordination skill. So how can you tell me it's not praxis? And she's like, well, it's a different function. I did my dissertation, or my thesis, master's thesis on this, and I've studied this, blah, blah. I'm like, okay, fine. And Dr. Ayers found this. Well, okay, here's what happened with Dr. Ayers. Dr. Ayers, using the SEPT, found two factor groups, two cluster groups. Bilateral integration and sequencing, which was vestibular-based, and somatosensory-based motor planning, right? Okay, here's the thing about factors and clusters. They will group together functions that are the same, okay, but are different from something else. So, for instance, I could group you all by ladies over here, gentlemen over here, right? Two groups based on gender. However, you're still all occupational therapists, right? So this is what happened with her factors, is that remember I said you organize your motor behavior to different sensory stimuli? So if you organize it to somatosensory inputs, it's motor planning. That group of kids fell out as their own group. If you organize it to vestibular inputs, it's a bilateral coordination and sequencing problem. They fell out as their own group. So they came out as two separate groups, but they're still praxis. Does that make sense? Okay? And that was later shown, oh God, I always forget her name. I can see her name. It'll come to me. The therapist who did the big, giant factor and cluster analysis for her dissertation. She found a common overarching function of praxis. Okay. That said, I've been thinking about my colleagues' points around bilateral coordination. And what I came to realize as I examined this more is that we're both right. Bilateral skills are praxis, but they are also not praxis. And the reason for this is that we actually have two kinds of bilateral skills. We have what I'm calling, and this is just me, bilateral integration skills, which are not praxis. Okay? Bilateral integration skills better go under our postural ocular movement disorder. They're postural foundations. They're cerebellar, they're interhemispheric integration. All right, this includes things like laterality, crossing the midline, handedness, all right? All of that kind of foundational bilateral skill. All right, does that make sense? However, we also have bilateral motor coordination, which is praxis. So buttoning my shirt requires foundational bilateral integration of laterality, crossing the midline, right? But it is a practic skill of bilateral coordination, motor coordination. I'm coordinating both hands of my body through a practic process, all right? And this involves coordinating and planning the two parts of the body. Might be right hand, left hand, might be arms and legs, might be trunk, okay? So skills like tying your shoes, riding a bicycle, all of those kinds of things. Those are our bilateral motor coordination skills. Does that make sense to you? Yes? Hopefully? Okay? So what I'm starting to do is to talk about these two different aspects of bilateral skills. Okay? So bilateral integration and then bilateral motor coordination. All right? And I will try to point those things out. We have to have that foundation of bilateral integration to do any other practic activity, right? Because our postural ocular movement issues, those are foundation for the rest of our praxis, to make our bodies work. All right? Okay. Yes, go for it. Yes, bilateral motor coordination needs bilateral integration. Now you can do it, but it's not going to happen very easily. So think about little kids before they've completely, fully developed laterality. They can do some bilateral motor coordination, right? But they're not very skillful at it. So as they develop better laterality, they develop better bilateral motor coordination. Does that make sense? Yeah? Yeah. Yep. Yep. No, no. Well, let me think. Yes, it would be, because he's rotating and he's planning. Right, and reaching. Yes. So, but he's using bilateral integration, which he has well developed, so he can cross his midline, right? And he has good hand laterality, so he's leading with his right hand. But the task of getting into the bag is bilateral motor coordination. Does that make sense? Yes. Yes. Yep. Yep. Right. Yep. Right. So you were using some prop. It was probably some of the proprioception. Yeah. Right. Yes. Feet. Yes, exactly. And remember, we rarely do anything that's just one thing, right? There's going to almost always be some aspect of planning, some aspect of bilateral skill. I mean, literally, almost everything we do requires bilateral coordination or bilateral motor function of some kind. All right, does that make sense? So we're artificially separating it out to learn it, but being aware that in clinical practice, it's often going to be a lot harder to distinguish. Okay? So something new for you to think about, all right? And I think it makes both of my friend and I are both right with our skills. Okay. Next thing. This is the Gestalt model of sensory integration, and this is the first page in your appendix. And when do I need to stop for break? When do I need to stop for break? What time? 11:30? Okay. Okay, got it. All right. Okay, so next thing then. And I'm going to tell you, I write out the schedule for you. It says, we're going to do this at this time, this time. Just ignore it, okay? Because I never stick with schedules. All right? Okay. Let's talk about this Gestalt model of sensory integration. This is, again, to make sure that we're all on the same page, okay? In terms of our understanding of sensory integration. So, first thing, we have the sensory integration process starts with registration of stimuli. Registration of stimuli involves detecting the presence of the input. All right? When we detect the presence of an input, we orient to it. Okay? And this results in an orienting response. There are two major aspects to an orienting response. We will either stop what we're doing or we will turn towards it. Okay? Now, here's an important point about this. Registration happens at a physiological level. We cannot directly observe registration. We can only observe orienting. However, humans, especially little autistic humans, can be very good about hiding orienting responses. Okay? So we may not see their orienting response. It can be very subtle. So that child, how many times do you have a child sitting there and people call the child, Johnny, Johnny, and Johnny doesn't pay any attention. And what do they say? They say, well, he doesn't register me calling him. Wrong, 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 wrong. Okay? Because what? Johnny was sitting there, and as soon as you said Johnny, his eyes went over to the side like that. His eyes flipped to the side. Well, what was that? It was an orienting response, wasn't it? But he had his back to us, and it's just this little eye flick. So we missed his orienting response. So he registered it just fine. He just chose not to respond. Okay? So what we need to do is we can never, ever say that someone has no registration. You can never, ever say that. What you can say, though, is he did not appear to orient. My practice challenge for today.
Hello.
Okay. Does that one work?
Hello.
Nope. Okay, so we can say that they did not appear to orient to it. Okay? If we definitely see an orienting response, then we can say they definitely registered it. All right? So we can say a positive, but we can never say the negative. Got it? Real important. All right. When we register input, two things happen at the same time physiologically. We modulate that input, we evaluate it for relevance, we decide what we're going to do to it, right? Similarly, we evaluate the qualities of that input for discrimination. So these two things happen essentially simultaneously in our nervous system, all right? Now, for modulation, this impacts largely arousal and attention. Those are sort of the two big impacts, which if that arousal and attention is not congruent, doesn't match the situation, then that child will be a behavior problem. That same behavior, on the other hand, in a different context, may be perfectly acceptable. Okay? So I think this is another really important thing. Behaviors tend to be considered problems when they are out of context to the situation and when they are more intense for the situation. So what is considered a behavior is very contextual. Thank you. All right. Oh, good. I'm back again. All right. So that's really important. All right. There's very few behaviors that don't fall in one of those two categories. All right. So for instance, some of our kids, they dig at their skin, right? And oh boy, that kid's got a behavior problem that we have to get rid of. That's a problem. But I sit here and I pick at my cuticles. That's my self-regulatory strategy. I sit here, I play with my cuticles. I chew my cuticles. That's no different than that child that's digging or biting, except for what? Intensity. Okay? The child is doing the exact same strategies that I do, but he's doing it in a more intense way. All right? So we need to go back and look at that behavior instead of immediately looking at it like, oh, this is all bad. Look at, well, why is he doing that? What is a less intense version of that behavior? And what purpose does that serve? All right? Okay. Discrimination, I mentioned, is our foundation for praxis and adaptive responses. We use these for skill. There we go, skill, okay? Now, in order to be organized beings, we have to have a balance of behavior and skill, all right? We have a balance of behavior and skill. So my behavior being appropriate for the context, my skill being up to managing the situation, all right? Now, what if I was not able to be flexible and to adapt to the differences in the setup for my teaching, or the back and forth we've been having with the microphones? All right? My skill is being challenged, right? I'm having to be flexible, I'm having to be adaptable. All right? Hopefully my behavior's okay. I'm responding by being a little snarky with my sound techs. Okay, teasing them a little bit. But I could have an inappropriate behavior that was more intense. I could start yelling, say, why can't you give me a microphone that's working? That wouldn't be very good, would it? You wouldn't like a speaker that was up here screaming at people, right? So the intensity of that response, the behavior, needs to be appropriate for the context, all right? And sometimes we all get a little cranky. I'm sorry, I didn't go out to dinner with everybody last night because I was like very sleep deprived and I was pretty cranky. I would not have been good company. And so I'm aware of that. I needed to go to bed. But I'm in good shape today, all right? All right, so that is our sensory integration process. Does that make sense to folks? All right? Okay. Let's move on then. Oh, yeah. The other thing I wanted to do here is just to point out that we have, oops, come back. We have all of these interconnections between these various components of praxis. That discrimination can impact arousal. On the other hand, like I was last night, I was really jet lagged. I'd been traveling for 30-odd hours. I had about 5 hours of sleep in 2 days, okay, and had been on 4 different planes and a hotel. And I had a very traumatic experience at the Mumbai airport. They took my knitting needles, out of my knitting. The security people. I was very angry. $100 worth of knitting needles they stole from me. I was very distressed. Okay? So, can you see I'm still distressed? I love my knitting needles. And they stole them. They were just little tiny skinny things. And he's like, no, you can't have them. I said, I checked before I left that it said online I could have them. No, they're not allowed. They're not allowed. I said, they're not going to hurt anybody. Look at them. They're like this big. It's like a big toothpick. No, you can't have it. He threw them in the trash. I was like, do you know how expensive those are? All right, see how that impacted my arousal level? All right, so arousal level can impact skill then, right? Trust me, after I left security, my arousal level was high. I was not very good. I'm like slamming all my bags in my, because they tore my bags completely apart. Everything out of my bags. They were like nutso there. And I'm putting everything all back, and I packed it all up, and I'm heading to the gate. And then I have this moment of, did I forget something? Because I was so distressed, okay? Did I like actually leave something? And then last night, I'm in the hotel, and I'm looking for one of my adapters. You know, I've got 3 or 4 different adapters for the plugs, you know, because I go all over the place. And so I've got to have your adapters. And there's one I really love, this little adapter. And I couldn't find it anywhere last night. And I was like, oh, man, did I leave that adapter at security? You know, I'm like, I think it was in a little bag, this little blue bag. Did I leave it in security? Did I forget it? Did it fall out of my bag when I was on one of the planes? And I was starting to get all upset about it again because I really love that adapter, and I've already lost my knitting needles. And then finally, I went through my bag, and I went through my bags, couldn't find it. I said, finally, I went one more time, and I found it tucked all the way in the bottom of a bag. So I was like, oh, thank goodness. But my skill was not that good. I'm like trying to work on this PowerPoint for you, because I had some last things I wanted to tweak. And I couldn't concentrate on it because my arousal level was so high. Now, I'm a functional person, right? So don't shake no, I'm a functional person. But imagine our kids with SI issues who don't have the same resiliency you or I have. What would happen to them? Instead of just getting upset, what would they start doing? Screaming and yelling, tantruming, right? Maybe lots of self-stimming, right? So we see lots of different things happen with these kids. So keep this in mind, that this is a dynamic interactive system. And all of the components can influence each other. All right? So hopefully that'll give you a bigger picture on Praxis. It's not all just about the motor, but other things can influence our ability to access our motor, and our inability to access our motor can influence our arousal. All right? Okay. Next thing I want to talk about is the concept of affordances. Is this a term you've heard before? Yes? No? 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 Okay. You're going to learn a little bit about affordances. The term affordances was developed by James Gibson, who was a psychologist back in the 1960s. He was very interested in looking at perception and how people perceive the world around them. And what he identified was that we perceive objects through their sensory properties. The light refraction off of them. We learn about texture, size, shape, luminosity, transparency, rigidity of the object. All these very basic properties of objects. And that through our interactions as we grow, as we develop as babies, we learn about what actions can be taken with different object properties. Okay? Because what do babies do? They take a new object, like a block, right? And they bang it, they slide it, right? They mouth it, they put it in things, they take it out, they feel it, they poke it, they rub their fingers on it, right? They are learning about object properties, but at the same time, they're learning, I can bang, I can squeeze, I can throw, I can take certain actions on objects that have certain physical properties. Does that make sense? Okay. So Gibson said that there's an interaction between the person, the environment, and the task. Okay? And that the properties of objects, and he extended this to the environment in general, they invite interaction. Because an object property might invite interaction for me, but not invite it for you. All right? That it's an individualized connection. Because I have different properties than, say, some of you gentlemen. Okay? So therefore, that object may not afford certain actions for me because I'm a short person, whereas it might afford actions to you as a tall person. Okay, does that make sense? Okay. Why did that do that? This should not be moving forward by itself. All right, he called them all action possibilities that are latent in the environment. Meaning that they are there in the environment waiting to be discovered by us. Okay? So this idea of affordances is important because our ability to recognize object and action affordances is the foundation for developing ideation for praxis. Okay? So if I say, I'm angry and I want to throw something, which thing am I going to throw? Am I going to throw the bouquet of flowers or am I going to throw the bottle of water? I'm going to throw the bottle of water, right? What is it about the bottle of water that makes it an appropriate action to throw when I'm angry? It's heavy. It's the right, it's a good size, right? We know it's going to fly far, right? And it's going to hurt. That's important. All right? So but the flowers, they're not, right? They're going to like flop down. They're not going to hurt, right? On the other hand, if I want to hit somebody, which is the better object? The flowers, right? Because I can take that, I could whap you, right? Whap you with the flowers. I'm being a little violent up here, right? Whereas this is not a very good object, right? Because it's not big enough, it's not long enough. We get too close, they'll stop us. So those action possibilities are important. This is my favorite affordance picture because look at what's happening in this picture. So we have a stone wall here, and we have a group of children. Look at the little boy in green over here on the right. What is he doing? He's standing there, right? And he's getting ready to jump off of the wall. So for him, this wall affords jumping off of, right? What about the little girl in the red skirt? What does the wall afford her? Running, right, it affords running. The little boy, the little blonde here in the blue up front, the little boy, what does it afford him? Climbing. But the boy next to him with the kippah and the jeans and the blue shirt, what does it afford him? He's like stepping, right? So two different affordances because they have different properties as people, right? And the little boy back there in the blue with the kippa, for him it just affords standing on. All right, so for each child, the same object has different action possibilities. Isn't it awesome? I just love this picture. Okay? So we're going to talk and think a lot about affordances for ideation. All right. This is just sort of that summary. Here's an example of the affordances. Recognition of affordances is related to our knowledge of actions and objects, and it facilitates our ability to know what to do with objects. Oftentimes with adults, I'll say, well, how do you know that this is the right object to throw at somebody when you're angry? Well, I just know it. Well, how do you know it? Well, you know it because you learned in infancy about object properties of plastic things and heavy things and what actions you can take with that. All right? And you were able to translate that into knowledge today. Isn't that cool? I love affordances. All right, next thing. That brings us then to functional implications of praxis on development. So what does this look like? So praxis problems cause lots of difficulties. They can cause problems generating ideas, planning and sequencing our actions, making choices about things, transitioning from one activity to the next activity, and accepting change. So just as to bring it back, I talked about executive functions. Does this sound familiar? How many of these things also sound like executive function problems? Right? I tell my therapists that when somebody comes into you with a child and they say, this child is really rigid and doesn't like to transition and always wants things exactly the same way, instead of immediately saying, oh, that's an executive function problem, which is what the psychologist is going to say, you're going to say, oh, maybe it's an ideational problem or a praxis problem. And I will guarantee you that in many, many, many cases, more cases than not, that child will have problems in those areas, okay? Because if you cannot conceptualize what's going to happen next, what do you want to do? You want things to stay the same, right? You don't want it to change. You don't want to sequence things. You don't want to transition from what I'm doing to the next thing because I have no idea what's coming up next. All right, does that make sense? Okay. Next thing, let's talk a little bit about what these kids look like. I promised you we were going to talk about observing, right? Thinking about what tells you that kids have praxis problems. First of all, these kids have poorly developed body schemas. And I'll tell you, when you see a kid with poor body schema, you know it because they're not in their bodies. All right? They don't have a good sense of self. We also see them having a limited repertoire of motor behaviors. So these are kiddos where you give them objects and they tend to do the same thing with them over and over again. All right? They are not very flexible about their motor behaviors. We see them wanting things to be the same. The big example is the child who pitches a fit because mom gave him, put less jelly on his toast today than they did yesterday. Or she made him sit in a different spot at the table. Or she didn't have his plate today. Sound familiar? Yeah, some of your kids? So that lack of flexibility, wanting things to be the same. As we observed in Ethan today, they often have problems using tools. So pencils, scissors, rulers, okay, any of those kinds of tools. We generally find them having poor organization. These kids are sloppy kids. Their rooms are a train wreck. I can walk into just about any classroom and have a kid open his desk and tell you which ones are one of our kids, right? You know those kids. Also, you go to their cubby, right, where their jackets and things are, and there's like 20 million shoes and boots and hats. Oh, you guys don't have hats and gloves. It doesn't get that cold here, does it? Well, we do. We're having snow. I'm laughing. They're having a snowstorm at home today. But you can tell, right? The backpack's there. Open up any kid's backpack, and you can see who's ours, right? Because there's all the papers stuck in there from like a week before. And he's the kid who's never brings home this, the permission slip because he can't find it in his bag because it's all full of other junk, right? All right, we also see them having poor coordination and sequencing of their body movements. These kids often just look awkward, right? They just look like they're not coordinating things together. Now, things that we see functionally, we see problems with them being clumsy, and as a result, they often get hurt. We do see them often having more broken bones, more bruises, cuts, and scrapes than other children. We see poor fine motor skills, so those pencil grips are awkward. We see them very frequently having delays in developmental milestones. The big milestone that is associated with Praxis and SI issues is crawling. These kids are delayed in crawling, or even if they're early crawlers and they're early walkers, it's the short crawling period. Okay, children should crawl at least 4 months, ideally closer to 6. If they crawl less than 4 months, that's a big red flag. Okay, so they can be an early crawler as long as they crawl an adequate amount of time before they walk. Okay? We also see them having poor tactile discrimination, so they're messy kids, right? Food on the faces, on their hands. They often don't wipe their bums very well, okay? So we see problems with hygiene. 5 minutes, okay. So we see problems with the body scheme. We see difficulty with sequencing and timing. These kids don't follow instructions. They can't do a sequence of things, especially, can't do 3 steps, maybe 1 or 2, right? We also see they're often late because they're so disorganized, they don't follow along. We also see problems with general gross motor skills, difficulties initiating or continuing activities, all right? We see problems with their mouths. They have like mushy mouths, right? So maybe they drool or they chew with their mouth open, or the mouth hangs open, right? You know who I'm talking about. And we see all those soft neurological signs, tremors perhaps, those retained reflexes like ATNR and STNR, all right? Okay, the next thing we want to see here, we see problems with these kids with sports, any kind of motor activities, sports, daily living skills like dressing, eating, handwriting. They take longer to learn things. This is really important. Kids with Praxis problems can learn to do anything. And they can actually become skillful in certain activities if they're motivated, all right? And particularly if those activities provide a lot of sensory stimuli. We had a child at the clinic where I worked for many years who was an Olympic level rock climber. Why was he so successful? He had really bad Praxis. But why was he successful? Because it had intense proprioception. So the activity provided an adequate amount of sensory input that allowed him to be skillful. I have another colleague whose husband is dyspraxic, has Praxis challenges, and he is an Olympic level rugby player. Again, why was he successful? Vestibular, probe input, right? Rugby is a really highly intense sensory activity, and it gave him the sensory input he needed to have motor success. Okay? We also see these kids being frustrated a lot. They get easily frustrated with tasks. And the big thing we see is they say, I don't know what to do. You ask them, what do you want to do? I don't know. How do you do this? I don't know. Right? We see that. Okay. Other things that we see here are problems with social emotional difficulties, daily life skills of all kinds, and this persists into adulthood. I have worked with many adults with Praxis challenges who have problems with daily living skills like cooking, doing dishes, loading the dishwasher, all right? Even managing clothing. They are very particular about their clothing because they can't manage fasteners. Copy machines, all right? Computers are problematic. Play skills are greatly impacted. And then academics, all right? Particularly the research has shown reading and math are the big problems. So, is Praxis educationally relevant? Yeah. Big time, in many ways. All right. We'll do one more here, and then we'll stop for a break, okay? So the last thing that we have here before we move on is last characteristics of kids. We see them often demonstrating a lot of what we call self-focused behaviors because they often have problems seeing other kids' perspectives. They may be empathetic, but they may not be able to put themselves in other people's shoes. So they tend to be focused on what their needs are. Therefore, when they're playing with other kids, they can be bossy. They need things to be their way, right? They're often either the leader of the pack because they have to be in charge, or they're the caboose follower because they don't know what to do and they sit and they watch first. So they can be either end of the spectrum. We also find them having problems socially, difficulties waiting their turn to speak or to interrupt, difficulty interrupting people. They're often in a lot of emotional turmoil because they're anxious, they're frustrated, all right? They don't know what's going on. We see them being very fidgety. We see them having problems playing quietly. They're often our little bulls in the china shop, right? Okay? And they often leave tasks unfinished, all right? And related with this, their timing of tasks can really be off. So relating to school, these are kids that take a lot longer to finish activities. So the teacher will say, get your math books out and get ready for the lecture. And everybody else is sitting there with their math books out, and our kids are still looking in their desks, right? Because they've gotten sidetracked along the way. I have a good friend of mine who's ADHD, and he says that he's very productive, but he loses track of time. And so he said, I will tell myself I'm going to go in and take 10 minutes in the shower and get out so I can get to work. And he says, I go to take my shower, and next thing I know, it's been a half an hour. And I don't know where the time went. So he gets distracted. And next thing he knows, it's 30 minutes later. All right? So time management is a big problem for our kids with Praxis issues. All right? So I think what we will do is stop here. All right? We'll take break. Are we going to have break or lunch? What are we doing?
Break. 30 minutes break.
15 minutes break?
Now the 30 minutes break, then lunch will be 3:15 after second session.
I would like to take this opportunity to express our sincere gratitude to ma'am for delivering a most understanding and interactive, interesting session of today's pre-conference workshop titled on the introduction of praxis and the functional implication of praxis on development. Her expertise, insight, and comprehensive approach have provided us with a solid foundation on the importance of the topic, guiding us to better understand how practice influences developmental process. And we got to know of two different new words such as embedded cognition and affordances through ma'am on, on her presentation. Thank you, ma'am. Now I will go for a small breakfast break, and continue our second session by 12 p.m. under the title Assessment of Praxis in Daily Life Setting. Lunch will be provided by 3:15 p.m. And I request all the delegates to have your discussion with our resource person during the break time. Thank you. Thank you.
It's okay, we'll work it. I actually prefer they not ask questions at break, because then I get no break. And it's like they're at you all the time. So it will work it out, don't worry. We'll make it work. somebody needs to turn their alerts off. We're going out of time. Whoever is that needs to turn it off. Okay. Thank you. Okay. All right, so we need to go until 2 o'clock, is that it?
Respected delegates, kindly get inside the auditorium and take your seats. The session is about to begin. Kindly take your seats.
Okay. I have a movable mic. Yay. It will be much better now. All right, let's have everybody take your seats. We're going to get started. We are running really, really, really behind, and my stress level's going up here. Okay, so talking about what these kids look like. This slide, I think, is really important, okay? This idea with our children with Praxis and SI challenges, we do not want to make the mistake of mistaking capacity for capability, all right? Many of our children with Praxis challenges have diminished capacity because of their SI challenges, but that doesn't, they're not capable of doing things, because they have problems, but they have the capacity. They just can't access that capacity. One of the things we want to keep in mind, is that many of our kids who are identified as having behavioral challenges, poor organization and planning, attentional issues, anxiety, may in fact have sensory processing or Praxis difficulties instead. All right, last thing I particularly wanted to call out, since we are talking about school systems, is what is the relevance of Praxis problems to school functioning? I actually had a therapist tell me a year or so ago, I was in an IEP meeting with a child, and the school-based clinician sat there to my face and said, Praxis is a medical condition and it's not educationally relevant. Yeah, I about had a fit, okay? Because as hopefully you've begun to see, everything kids do in school, from being able to write, to being able to develop their executive function and cognitive academic skills, is related to Praxis, all right? So we see Praxis being related to those executive function abilities. Being able to do daily school tasks, organizing their homework, their handwriting, problem solving, all right, being able to oops, sorry, this didn't go forward. Hold on, we'll come back. There we go. All right. Social skills. Social skills are related to Praxis. When I walk up to someone and I say, hi, what is this? This is Praxis, right? It's timing spatial awareness. It's timing my motor. So much of our social interactions are founded in Praxis, all right? Safety is another really important issue. These children with Praxis challenges are clumsy kids. They're crashing into desks. They have problems navigating the classroom, all right? Get them out on the playground, and it's all kinds of disasters, right? They're more likely to get hit by swings, to get in the middle of other children's play, of being able to trip and fall or not be able to use playground equipment effectively. And lastly, we see these kids demonstrating a lot more behaviors and having problems with self-regulation due to their arousal issues and problems with frustration. Okay? All right. Relating Praxis to executive functioning, we see that relationship to the development of cognitive processes through embodied cognition. It also helps us be able to attend and control impulses. If we know what's coming up next, if we can anticipate action, we are more likely to be able to wait. When we cannot anticipate action, we're more likely to be impulsive. Okay? In addition to this, our language functioning and our organization of action and representational thinking is all related to Praxis skills, particularly that ideational component. All right? Now, the research suggests that these are separate but related functions. All right? Think about it like here's Praxis, here's executive functioning, and they overlap like this. Okay? And the big denominator here that distinguishes them is time. So I can plan what's coming up motorically for Praxis in the immediate future. Okay? I'm going to walk over here. I can plan my motor planning 3, maybe 4 steps in advance. Beyond that, I'm now planning conceptually. All right? I'm planning just in my head. I'm not planning my exact motor movements, but I'm planning the conceptual actions. At that point, I'm now using executive function planning. Okay? And then when I get to that point, I use my motor planning to implement that action. Does that make sense to what I'm talking about? Okay? So it's really how far out in advance we're planning is where that line draws. All right. In the classroom, we're going to see problems with rigidity and impulsivity, acting out. I mentioned handwriting, reading, math, organizing materials in the desk, not being able to complete assignments, okay, and clumsiness around the classroom. So this is just sort of your summary. So when anybody says, well, Praxis isn't educationally relevant, you pull this slide out and you say, oh yeah, here it is. Okay? All right. All right, does everybody have a better idea what these kids look like? Hopefully? Okay? All right, let's talk now about assessment. So, first of all, this is a poll for you here. Do you currently, in your practice, evaluate Praxis functions? Explicitly evaluate Praxis functions. All right? Yes, you routinely evaluate them. Sometimes, no, because you don't think it falls within the scope of school-based practice. No, you don't do it, but somebody else does. Or no, you don't do it, but you'd like to be able to. So let's just take a little poll. First of all, let me ask, how many people are students and don't evaluate kids at all yet? Anybody students? No? Okay. All right, how many people? Yes, you routinely evaluate Praxis. Let's see your hands. Raise them up. All right, I want you to take a look. This is sad, people. Very sad. All right. Let me ask this. How many people don't work with kids? Everybody here works with children? All right. If you're working with children, you should be evaluating Praxis. Okay. Next question. Sometimes you evaluate. How many people sometimes evaluate Praxis? Anybody? Come on, raise your hands. There you go. Good for you. All right. How about no, you never evaluate it because you don't think it belongs in the schools? Anybody? No? Okay. How about no, you don't do it, but somebody else does? Okay. And how about no, you don't do it, but you'd like to be able to? All right. There's a lot of people out there who have not raised your hands. I told you, this is active participation. Do I have to come up there? Let's try this again. Every hand should come up with one of these options, right? And I'm seeing a lot of no hands. I'll come up there and get you. Okay, let's start at the bottom. No, you don't evaluate Praxis, but you'd like to. That's better. Okay. Much better. See, you can raise your hands. You have practicabilities. All right. How many people, yes, you sometimes evaluate it? That's much better. See, you didn't raise your hands the last time. Thank you. Okay, anybody think it doesn't belong in the schools at this point? Oh, good. I'd be unhappy. All right, what about no, you don't do it, but somebody else does? All right, we still have a lot of people who didn't raise their hands. But the point being, we need to think about evaluating Praxis. Let me ask you this. How many people would like to evaluate Praxis but feel like there are barriers to doing so? Not enough tests, don't have time, don't know what to look for. Does that sound familiar? Yeah, okay, we're going to talk about it, okay? All right, first of all, let's start with the easy tests. All right, what's the easiest thing to use for evaluation? Parent report measures are always a good place to start. And I want you to write that down. It's a place to start. It is never, ever, ever the only thing that you use to evaluate sensory integration or Praxis. Research shows that parent proxy reports and what people actually document as themselves, agreement is not 100%. People often report differently what is reported via proxy, okay? So parent reports, we looked at this with our adult adolescent sensory history, and we found that caregivers, parents, spouses, underestimated the severity of problems that were self-reported by individuals, okay? So proxy reports are an indication of things that might be problematic, but you have to do direct assessment of some sort. Now, what measures are available? These, there are three major ones. We have the sensory processing measure. I prefer this tool. Now, I know here you probably run into translation issues. Is that a big issue? Okay. The SPM is problematic because WPS, for some reason, is really hard to get permission to translate their instruments. Has anybody run into that? Anybody tried to do that with them? It can be a problem. I don't know what their issue is around it, but I know that people have complained that it's hard to get the SPM translated. I prefer it as a parent report measure because it has a Praxis section on it, a motor section specifically, and it covers discrimination of sensory inputs much better than the sensory profile. The sensory profile is pretty good about translations, and so it's used widely because it's Pearson, I think, is the one who owns it. They're quite open to translating. However, the sensory profile stinks as a measure. Okay? It really primarily evaluates modulation challenges. Okay? It really does not pick up on motor, and it will miss children with praxis problems who don't have overt modulation issues, and it does not do a very good job of picking up discrim issues at all. Now, if you have older children, if you're working with teenagers, 13 and above, I recommend the ASH. This is my assessment. Okay, we developed this through, at the Spiral Foundation. It's the Adult Adolescent Sensory History. It uses Ayers' SI model, and it gives you lots and lots of different breakdown of scores. You can use it as young as age 3, and we are very open to having it translated. We've been working with a number of different people. So if that's a project somebody wants to take on, you can contact Allison at the Spiral Foundation, and she will work with you on doing it the way we need it done. Okay? So these are the 3 tools that I recommend. Now, the next thing then is traditional praxis assessments. Historically, we've had the SIPT, right? And the SIPT has these various praxis assessments which evaluate the different aspects of praxis. Remember we talked earlier about there's different aspects to it, that you're going to have different results if you're doing imitation, if you're doing self-initiated activity, if you're doing sequencing, if you're doing 2-dimensional or 3-dimensional or oral. The SIPT, unfortunately, is now pretty ancient. And the problem is that WPS has gone in with Lucy Miller and has put their assessment for sensory stuff into the sensory processing measure 3 dimensions, the SPD 3D, which is not yet out. But it's supposed to be out anytime, they keep saying, for the last 4 years. But it will be out eventually. So that will be an option. The downside to that tool is that they're using the SPD model for their categories. So you will not get the categories that you got with the SIPT. The other option for assessment tools is the EASY, the Evaluation of Ayers Sensory Integration, which was developed by Zoe Malo and Susan Smith-Rowley and other colleagues. They have been doing a lot of work on the EASY. They're doing a lot of training, very obviously open to translation. Been working with a lot of, I think they've got over 100 different languages for the EASY, so it's probably your best bet. I find it still a bit awkward to give. I know some people who use it a lot really like it. I've just challenges my old praxis, so it's been a little harder for me to switch over to at this point, but I'm trying. I do still like the Miller assessment for preschoolers. Although that tool is not published any longer, you can still get the forms if you have a test kit. It is old, but for children 2 to 5, it's the best assessment available unless you're trained in the EASY. If you're not trained on the EASY, then the Miller is really the best assessment. So I recommend that if you have access to it, that you still use it. Other things that we can use are Ayers, formal Ayers clinical observations. I'm going to go over those with you. If you're short on time, the 3 biggies for praxis are didactokinesis, sequential thumb, and sequential thumb finger touching. Those are 2 examples. So if you don't have time to do anything else, you can do those 2 as quick and dirty. And then we have our informal clinical observations, our observational assessment, which we're going to go over next. So here are a few other possible assessments. I mentioned the EASY, the SP3D. As you noticed with Ethan, the little boy we watched this morning, you can use the bot and whatever, I think it's up to the bot 3 is coming out now. I am assuming that the bot has probably been translated. It tends to be one of them that is used a lot. It does not directly evaluate praxis, but it will look at motor skills, and you can make, obviously, like we did today, you can make a lot of observations with it. It does have, I think, one of the better assessments for bilateral motor skills. And then our AIRS clinical observations. So one of the things that we run into with praxis assessment, barriers. First of all, assessments are often very expensive. For instance, the EASY costs thousands of dollars to get trained on. The test itself is not expensive. They've tried to make it very affordable for people, but they require that you do all of this training. You have to do like 5 classes in order to get trained on it. And it's just outrageously expensive, thousands of dollars. So that can be a big barrier, especially when you guys are looking at translating your currency into US currency. I'm talking thousands of dollars US. Another problem that we run into is that a lot of our kids can't do long standardized assessments. You know, you've got a 5-year-old with autism, you know, level 1 autism or something. They're not going to be able to sit down and do, you know, 2 or 3 hours worth of testing. So we have to have alternatives to that that long assessment. Another problem we've run into is the restricted age ranges. The SIPT was limited to children 4 to 8, 9. The EASY is looking at going, I think, from 2 or 3 up to 12. They don't have norms for that age group yet. I think their norms are 5 to 9 at this point. So the problem there is the having ages that are appropriate. Next thing is that it's often time consuming, all right? These tests take a long time to get prepped for. They take a long time to administer. And to sit down and score them, it takes even more time. And I know that for those of you who are working in the school systems, this becomes problematic. I just signed a contract with a local charter school district in Pennsylvania, and they're paying, they wanted to pay me $140 for an evaluation, okay? As a private practitioner, I charge $1,200. And they wanted to pay me $140. Yeah, I said no, all right? Because there's no way, you know, $120 is for a 15-minute hand eval for hand rehab. It's not for a comprehensive school-based evaluation. All right, the last thing that we run into is also that many of these tests don't address adaptive responses to the environment. All right, they're very limited. What are you doing? You're evaluating praxis, and the kid is sitting there, right? They're not really oftentimes manipulating objects. It's a lot of imitation, and imitation is only one aspect of praxis. Okay, so we run into difficulties. So one of the things we can do here is, this is what I recommend, that if you're short on time, we can cobble together a praxis assessment that can give us a lot of good information, especially for school-based practice. The first thing is the movement assessment battery for children. This is a widely used tool. I'm assuming that it's translated because it's used worldwide with researchers. It is an expensive test because it comes from the UK. I know for us it costs a lot to ship in, but I do think if you had to buy one tool, I would recommend it. It's only 8 items, It goes from ages 3 now up through, I want to say, well into the teens. So the age range is pretty good on it. I like it because it's 8 items, so you can finish this test with a cooperative kid in about 20 minutes, all right? So you can go pretty quick, and once you get used to it, you can go through it pretty fast. It picks up children with vestibular-based bilateral coordination and projected action sequence problems. It is not good at identifying children with motor planning problems. You can make some observations on it, but it was designed for kids with DCD who had motor coordination difficulties, which is really your vestibular-based stuff, okay? So it covers that aspect. Consequently, we have to supplement it. What do we supplement it with? First of all, you have to do some kind of tactile testing. It has some balance items, so you can get some vestibular stuff there, but you want to do the tactile. So finger identification and graphesthesia. These are your best items. So SIPT, you can use them, or you can use those 2 items off of the EASY. All right, you do have to pay for the scoring of those 2 items, but if you're only doing a couple of items on a disc, you know, you get 150 scores on the disc, you can evaluate a lot of kids with that, all right? But that'll give you your tactile tests. Next thing then, and I've also showed you here, these 2 tests you can finish in 5 to 10 minutes, so they're fast. The MABC takes about 20 minutes. You can also use a couple of items on the quick neurological screening if you need something else, all right? It doesn't give you a standard score for that item, but you can at least look at that item. Then you want to supplement a parent measure or a teacher measure. So the SPM is a good measure to use, we mentioned. Then I have 3 assessments for Praxis that I've been working on developing that address different aspects. So I recommend you use those because I developed them to help therapists have quick, fast assessment. The first of these is the TIP. The TIP takes 5 minutes. It's the test of ideational praxis. It will evaluate that ideational aspect, okay? Only takes 5 minutes max to administer, and once you get used to scoring it, you can score it in 5 minutes. Then I have what I call the test of gestures, the TOG. It's a imitation of postures assessment, but it also has following verbal command, and it gives you a comparison between doing things to imitation as well as doing things to verbal command. That test I don't have much in the way of research on at this point. People have been using it clinically. They like it. Anybody want to do research on it? Let me know. I'm happy to do some with you. The TIP has quite a bit of research on it at this point. The next one then is the motor planning maze assessment, which takes 5 minutes to give. There are 3 mazes, and there's a fair bit of research on this. I have more research coming out on it out of Turkey that will have several more papers on it, and it'll be normed in Turkish as of the end of this year. So I'm excited about that. The translation paper just got submitted for publication. This test was based on wire mazes that Dr. Ayers used in her early research. Okay, I've adapted them and adapted the scoring. We do have some preliminary normative data on this, so it's got some psychometrics, and it discriminates really well as an initial screening tool. It is not good for test-retest, okay, but it's great for screening. I like it because it involves manipulating objects, looking at object affordances, okay, and you're actually interacting with the environment. Then we have Ayres clinical observations. And what I tell people is do as many of Ayres clin obs as you can squeeze in the time that you have. At a minimum, we want to do prone extension and supine flexion. We want to do post-rotary nystagmus. We want to look at ocular motor control, okay? If you're going to look at ocular motor, you can easily look at muscle tone and postural stability. And then anything else over and above that you can do. Diadochokinesis, sequential thumb finger touching, all right? I'm going to give you those. You can do all of this assessment in about an hour. And an hour is about what you're given for school-based evals, all right? So with this, you can really get some good praxis information in the allotted time that you have. All right, in addition to that, we can do observation. All right, so we're going to spend the next bit of time here looking at observational assessment. What can we look at just using our eyes? We can go into the classroom. We can go into gym class. We can go into watching the child on the playground and do some assessment of their sensory and praxis challenges, okay, just by doing observation. So let's start off with Ayres clinical observation first, because structured observations are always best if we have time to administer them, all right? These are a supplement to our standardized tests. Usually, they're primarily tests of soft neurological signs. The majority of them evaluate aspects of vestibulo and vestibular cerebellar functioning, all right? Some proprioception. When you're looking at clinical observations, it's best to look at patterns of functioning, all right? So taking one test out of context is not always that useful. We want to look at what are a pattern of responses and how do those patterns of responses fit with our clinical observations. The other thing that's important about praxis is that praxis is very much about quality of performance. Oftentimes, children can do skills, okay? They can tie their shoes, they can get their jacket on, but it's the effort with which they do it. It's the quality with which they do it, all right? It's how easy or how hard it is for them. So often when you're evaluating praxis, it's not so much about can they do it or not, but about how they do it. All right, so we need to start kind of fine-tuning our eyes to identify those qualitative aspects of performance. Okay. All right, so these are the areas that are evaluated by Ayres clinical observations. I am not going to show you how to do these. I do a whole one-day course on ClinObs, all right, how to administer those. But I want you to start thinking about them, okay? And then you can take the next course, right? This is all going to be about take the next course, right? Because praxis is like big, right? It's big, and there's courses for all the little pieces. So first of all, we have to evaluate sensory functioning, particularly vestibular, proprioception, somatosensory, tactile. These are the biggies. We want to look, some of the items look at cerebellar functioning, some of them look at postural ocular control, some look at reflex integration. And yes, reflex integration is important. It is a red flag that there's a problem when reflexes are not integrated appropriately. We specifically look at motor skills and praxis skills, bilateral coordination, and projected actions. So you can see that if you go through all of the ClinObs, you can really get a lot of good information just by doing that. Okay? All right, what I want to do here is I've taken the clinical observations And I've broken them down into different categories that tells you what those clinical observations tell you about. All right? Some tell you about more than one thing, so they'll be on more than one list. Okay? But this will be good reference material for you later on when you go back to the clinic on Monday or Tuesday. All right? So, proprioceptive and somatosensory processing. Which ClinObs tell you about this? Muscle tone, proximal joint stability, slow arm movements, diadochokinesis, sequential thumb finger touching, tongue to lip movements, prone extension, and neck flexion in supine flexion. Okay? Now, let me ask you this. I'm throwing a lot of words out here at you. How many of you are familiar with Ayer's clinical observations? Some. Okay, that's good. How many of you have no idea what I'm talking about? A few. Okay. The rest of you are afraid to admit that you don't know what I'm talking about, right? It's okay to say, I have not heard of them. I don't know what you're talking about. That's why I'm here, right? To teach you. So what I'm going to do with this is I'm going to show you pictures in just a minute about what these look like, okay? So you can get an idea of what they are looking like, all right? Some of these are on the quick neurological screening. You'll recognize some of them off of the quick. So if you're not familiar with Ayer's ClinObs, you can do the quick neurological screening, okay? All right, so this is proprioceptive processing. So if you want to get information about proprioception or somatosensory processing, these are the ClinObs you would do. Now, for cerebellar functioning, these tests look at cerebellar functioning. Slow arm movements, diadochokinesis, sequential thumb finger touching, finger nose, equilibrium and writing reactions, ball skills, projected actions, and bilateral coordination. Okay? Praxis observations, motor planning. You can make observations about this with slow arm movements, diadochokinesis, sequential thumb finger touching, tongue to lip, supine flexion, hopping, projected actions, and bilateral coordination. And you're going to see that there are specific activities under projected actions and bilateral coordination. Okay, for bilateral coordination and projected actions, the ClinObs of slow arm movements and diadochokinesis can tell us information about that because they're bilateral activities. STNR, ATNR testing, ball skills, and then these specific activities for projected actions and bilateral coordination. So let me show you now what this looks like, now that you know the categories. All right, so here's slow arm movements. What you do is you ask the child to start like this, and in 6 seconds, so it's not very fast, they extend their arms, and then they bring them back in. Okay? So you can see here that we're looking at bilateral. Is it symmetrical? Do they have good awareness of their body? When they extend their arms, do they get full range of motion, or do they go like this? Or do they flip, flop? So this can tell you about proprioception. Diadochokinesis is our rapid alternating forearm movements. That's this one, yeah. Look familiar? And then we do both at the same time, okay? And we'll sit with them doing it on their lap. They took all my chairs, so now I have no chair to show you. There we go. That needs to shut. It's too noisy. Okay, we got it. All right, so diadochokinesis is like this, okay? All right, so we can see if they're doing this. All right? This is quick, a little mini version. Sequential thumb finger touching. I have the kids hold their hands back here because if it's back here and they need to visually monitor, they will pull their hand in front. That way you can very easily see if they're going to visually monitor their action. If you have them do it like this, they will visually monitor what they're doing. Okay? So we do 2 hands together, up and down, and then one at a time, and then the other. So right, left, and both together. Okay? Tip to tip. Next one is tongue to lip movements. These are you're familiar with. Up, down, side to side, make a circle. Okay? Finger to nose touching. Okay. We can also look here, proprioception. Do the arms go out? Do they go like this? Can they keep their shoulders up? All right. Supine flexion. We want to look at neck flexion. That chin should be tucked in. Hers is not tucked as well as it should be. She actually told me afterwards she'd had a neck fusion at one point. So she had a couple of vertebrae that were fused. So she actually could not tuck her chin in. But our kids should get chin tuck. There's some examples. This is poor supine flexion. Notice this little guy's pelvis is not really up off the ground. His shoulders are not up off of the ground. This is my son. He's got very good flexion. Okay, bilateral coordination skills include jumping jacks. And I want to point out here, jumping jacks are getting the arms all the way up, not this business. I don't know where this came up. Do they do that here? Like that? Who did that? That started that years ago, and now it's like a thing. No, when I was a kid, you did jumping jacks like that. Got to get those shoulders involved. Okay, there's another example of jumping jacks. Other bilateral coordination skills involve skipping and galloping. You know what galloping is? Right? Galloping. You know what skipping is? Alternate. Okay? Then we have cross crawls. You guys know cross crawls? I can't do cross crawls. I don't reach that far. There you go. Hey, I'm getting better. Okay? Great to look at trunk rotation. All right. Another bilateral coordination is stride jumping. So you remember this off the bot? Yeah. Same side, and then alternating sides, right? So this is why I like the bot bilateral section. They've got really nice bilateral activities. And then ball skills involve tossing and catching playground-sized balls, okay, as well as tennis balls. So we want to look at, can they do small balls and bigger balls? Toss and catch, roll the ball to them so they kick. We also want to see, when they're doing this, can they step to the side? So when you roll the ball, you don't want to roll it directly at them. You want to roll it a little to the side to see if they will do that projected action of anticipating the trajectory of the ball. All right, does that make sense? Okay, same thing with tossing it. Toss it directly to them a couple times and then toss it to the side. All right. Now, who knows what projected action sequences are? I've been kind of using that term all morning. Anybody know what it actually is? Or is this a new term? New term? Okay, projected action sequences are motor actions that involve timing and movement through space. So it involves projecting one's body through space and navigating spatial and temporal aspects. So, crossing the street with all the traffic is a projected action. Navigating around a classroom, avoiding the kids and the desks is a projected action. Almost all sports are projected actions, okay? Do you need something, or are you just standing? Just standing? Okay. I just wanted to make sure you didn't need to make an announcement or something. Okay. Ball skills. Okay, all ball skills, tossing, catching, hitting, those are all projected actions. Okay, so activities like hopscotch is a projected action. It's a very nice, easy activity. Another thing you can do is tape down squares on the floor and have kids jump through the squares. What we want to see is them doing this nice forward, feed forward, anticipatory action instead of, okay? That's not good projected actions. You want that body to project through space, okay? Now, the other thing I forgot to tell you about, and I should put this on my slide, we also do have the SOCM. Okay, you guys familiar with the SOCM? I know some of you know Erna. Okay, Erna Blanche and Gustavo Reynoso developed the SOCM, and it also has the proprioceptive questionnaire with it. The SOCM is basically Ayers-Clin-Obs that have been standardized, all right? They're lovely. It's a nice test. If you need scores, and many school systems require numbers to qualify for services, the SOCM is a good alternate, it's a good version of the Ayers-Clin-Obs that will give you numbers. If I don't need numbers, I don't bother with it, because I don't need it to do these to give me the information I need, okay? But if I need numbers, then the SOCM is a good option, okay? All right, that is our clinical observations, all right? Does that give you a little bit of an idea about what to do with some of that? I know that was really quick and dirty, all right, but it should give you a little bit of background on these areas. You're going to need to take more training to learn how to do them, how to interpret them more, know what nuances, but that's another course, okay? All right, that brings us then to observational assessment, clinical assessment. What we're going to do now is we're going to start looking at our questionnaire, our instrument that's in your notes. So what I'm going to cover now is all going to be on this assessment, okay? I'll give credit where credit is due here. Some of this I developed myself. Some of it is from some instruments that we used and developed at OTA, the Kumar Center, where I worked for years. So some of my colleagues, you'll see I have some other contributors there, okay? So this is a kind of a bit of a mishmash from a lot of different people, okay? But it's my organization. So let's go through this. So what I've done with this measure is we have these various forms that we developed for clinical practice in the clinic. As I was developing this course for you today, the emphasis was obviously on schools. All right, so what I've tried to do is to take out things that aren't observable in a school setting at all, and include things that are school-based or that you could see in the school, and try to focus this on praxis in the schools. All right? So I've also included on here some of the foundational sensory processing. It's not comprehensive, but you have to do a certain amount of sensory assessment to really understand the foundations for praxis. So I felt like we needed to talk a little bit about sensory first. Okay? So before we do that, though, the first thing we want to talk about is preparing for your observational assessment in the school. If I were to do this assessment in my clinic, I would bring the child into my treatment room and have them do different activities on the swings and such in my clinic, and I would do my observational assessment in that setting. But you're going to be in the school system, right? Some of you may have a treatment space that you can bring the child into. Fabulous. But many of you will not. Many of you are going to be in the schools. So we need to do our observations elsewhere. So we need to collect some information. First of all, we have to identify where we're going to do our observation. Are you going to do it in the classroom during history class? Probably not the best alternative, right? On the other hand, art class or gym class might be really helpful. Transition between classes or free play time might be a good time. All right? So you need to identify when during the school day and where you're going to do your observation. You may also do your observation in more than one setting. All right? Maybe you want to do it in the cafeteria for a few minutes and in the classroom during math class for a little bit. Okay? The next thing we want to do is note the type of room environment. And so if you look in your notes, you'll see I've got different kinds of room environments. Is this a traditional classroom? Is it an open classroom where there's a lot of noise and people moving around? Is it a split class where there's like two halves to the room? Maybe it's a dual grade classroom where you've got first and kindergarten, K1, something like that. Is it a resource room? All right. Is it other therapy services? Maybe you observe during speech. Is it the gym, the playground, the cafeteria? All right, any of those other potential options. Another thing you actually want to look at is the physical layout of the space, because that's going to inform your observation. How big is the room? Is it a big room like an auditorium? Is it a little teeny tiny space because you're observing him during speech and it's a closet? You know, sitting at a table? Or is it a regular sized classroom? Also, you want to look at, well, how many people are in the classroom? Is this a traditional classroom and they've got 5 or 6 kids? Or are there 30? And how many adults are present to corral these kids? Is it 30 kids and 1 teacher? And they're expected to sit in lines? Okay? Or how are the desks arranged? Are they in lines? Are they in little pods? Okay, little groups? What's the layout of the room? Because that's going to inform how your child performs. All right? A lot of our kids can't handle the traditional line-it-up classroom. They do much better when there can be 1 or 2 desks or 3 desks together. And we can orient them so they're not facing the rest of the classroom. All right, different things like that. We also want to look at what activities are happening during your observation. All right, are they in math class? Are they during music? And in music class, are they sitting around in circles? Or are they, doing musical chairs? All right, so you're going to need to write down the kind of activity that you're evaluating. Because if you're only looking at this kid and observing at this child sitting in his chair, you're not going to learn a lot about praxis. You can learn some, but you're not going to get the whole picture. Okay? Last thing, you want to evaluate the sensory environment. Okay? And I've given you a few examples of the environment. The big things that you're going to look for in the environment are the visual and auditory characteristics. So we've noticed here, auditory. What's the auditory characteristics of this learning space? They're terrible. They're terrible. There's extraneous noises out here. There's buzzing. There's banging. There's people talking. Okay? As a speaker, that's really hard when people talk. All right? So the auditory component is challenging. All right? There's echoes. It's a big room, so there's echoes. Actually, there's not much echo in here. That acoustic's not too bad. But you may get a lot of echoing in a classroom. All right? So you want to consider the auditory things. You also want to look at whether or not there's a lot of extraneous noises. Is there buzzing from the lights? This is very common with fluorescent lights. All right. The next thing you want to look at, see, there's an extraneous noise. Sounds like it's going to rain. Okay, then we have visual. So let's think about the visual characteristics. Is the classroom crowded? Is there a lot of stuff on the walls that's visually distracting? And are there a lot of colors that are going to draw the child's attention? Look up. Everybody look up. What do you see? Flashy light, right? Is that driving anybody crazy? I've been able to ignore it. But that kind of flashy light, okay, that's a big problem in a lot of the classrooms. A lot of our kids can't handle that. Another thing we want to look at is olfactory and tactile. Many rooms have odors that can be problematic for our kids. Is it musty? Is there smells coming in from somewhere? Okay? And then tactilely, things that you want to look at are particularly temperature in the room. Is it cold? Is it hot? All right? And drafts. All right? Are there drafts in the room coming from air conditioners? Well, you guys don't use heaters probably, right? But we've usually got air blowing from heaters or maybe windows being open. You get air blowing in. It might feel good to us, but for our kids who are tactile defensive, that air blowing across the hair on their arms can be very problematic. Okay? So these are things that we want to evaluate and note because they're going to influence what's going on with the kiddos. So here's an example. What do you think of this classroom? Pretty typical, right? But is it a good classroom for our kids? It's very distracting, isn't it? Look at, everybody likes color, but look at all the stuff that's out there in the open that's there to draw a child's attention away from the learning. Okay? So this is an example. Now again, the layout may not be bad, but what if this kid is sitting here? Well, he's got somebody right behind him. That's going to be distracting, right? So where is your child seated in the classroom? And how does that impact on his behavior and his ability to engage? Okay? All right. When we are doing observational assessment, there are 5 major areas, 5 key areas that we want to think about. And what I've tried to do is to organize this assessment and organize our discussion around these areas. So the first of these is state of arousal, which includes our sensory modulation. Because if you're not in a good state of arousal, you cannot access the abilities that you have. Okay? So if I'm really discombobulated, like I was when they stole my knitting needles, I was so disorganized. All right? Like all day yesterday. Even this morning when I woke up, I was still angry about it. All right? And that disorganizes you. So if you're not in a good state, that can impact on your ability to do skill. All right? So we need to evaluate state of arousal. And that also then is often influenced by modulation problems. Then we want to look at indicators of sensory discrimination and postural challenges. I am not going to talk a lot about postural challenges in this course. There are observations for that on the assessment. We'll talk about it just a teeny bit, but I'm not going to get into depth with it. You can. I'm not going to do it. I want to spend time on the praxis. Next, we want to look at quality of motor skills. This may be posturally related, but it also may be the quality of your praxis ability. How did they do it? Then we want to look at the aspects of praxis. So can they create plans, come up with ideation? Can they access their motor planning? Can they modify their plans? Can they accept feedback and recognize feedback and change what they're doing? Okay? And then lastly, how's their organization of behavior and their problem solving? How does this then translate into those larger skills? So let's start off and take a look at children's behavior in the situation. Okay? So what are we looking for? Because we need to know behavior first, right? What's this kid look like in this setting? First of all, how does the child react to other people? Do they engage with them? Do they make eye contact? Do they vary their facial expression? Okay. Do they demonstrate appropriate affect for the situation? Many of our kids are not doing these things, right? They're not paying attention to the teacher. They're laughing out loud or calling out when they're not supposed to. So these reactions to others are challenged. They're not making a connection with the instructor, with the teacher or the aide. All right? The next thing then is how do they react to the task demands that are being placed on them? So do they need to have the support of a teacher or an aide in order to do a task? You know, is this a kid who won't get his books out of the desk without the teacher coming over and saying, Johnny, get your book out now? Or they need an aide to help them get to the right page. All right? What does that look like? Are they able to follow requests, follow instructions? Do they need multiple repetitions to do so? What about being able to stay on task? Can they stay on task and follow something through to completion, or do they, get lost in the middle of it? What's going on with that? And then can they transition between tasks? So, all right, it's time to finish our math problems and go on to reading. And they're like, no, but I'm still doing my math. I'm not done yet. I need to do my math problems. And they're still working on math, and everybody else is ready for reading. Sound familiar to our kiddos? Then, are there notable behaviors that the child is demonstrating? And these are listed from a behavioral perspective, but I only do that because it's a way to organize information. We're looking at the sensory foundations for these behaviors. So for instance, are they doing avoidance behaviors like hiding, turning away? You know, is that kid always turned around in his seat? Does he have his head down on the table, hiding his face? All right? Is he demonstrating those kinds of behaviors? And if so, why might they be doing those escape behaviors? Is it that the task is too hard? Is it a sensory stimuli that's too difficult? All right? Try to discern why they're doing that. Next thing is attention-seeking behaviors. And these are things like calling out, teacher, teacher. Or she's in the middle of a lecture, right? Hey, what about this? You know, I like that. Sound familiar, right? The child's calling out. People will say, well, he's just trying to get attention. Or he goes over and he's pulling on the teacher's sleeve. Hey, you know, Miss Smith, Miss Smith. Yeah. But why? Why is he doing that? Maybe he needs, people look at it and they say, it's attention seeking. But what is it about the attention that he needs? Is it that he has poor impulse control? He can't inhibit his behavior. Is it that he needs the teacher to help him keep track of what's next? So it's teacher, teacher. Okay, why is he doing these behaviors? And then are there any kind of aggressive behaviors that occur, like hitting or biting, okay, spitting? These are maybe signs of overload, all right, or frustration. So we want to make notes about these things. Does any of this happen during our observation? Next thing we want to look at are observations of arousal and sensory modulation. So starting with arousal level, most of the time we're going to be dealing with high arousal, okay? High arousal is usually the problem. And physiologically, our kids with modulation challenges tend to be in that high arousal state. I personally don't really like this idea of low under responsivity as a sensory modulation problem because I don't feel like I've really seen it. Okay, kids that appear to be low arousal, all right, who are under responsive are generally one of two things. I usually see them as being poor discrimination so that the intensity of the input is not enough for them to discriminate. Am I being touched or not? I don't know, because it's not meaningful information. Or it's overload and shut down. I'm too overwhelmed. I cannot handle anymore, so I'm going to shut down. I was in shutdown last night. Okay? Overloaded. So what happens when we get overloaded? We shut down. Okay? It's just like, don't talk to me, don't look at me. I don't want to do anything, just leave me alone. All right? So I have probably seen I've been practicing over 40 years, close to 45 years here. And I have probably seen a handful of children that I felt had physiological low arousal, under responsivity. And every one of those kids had a generic cognitive dampening. It was like cortical dampening. Okay? So I do not feel like it was a sensory modulation problem. It was an overall cortical inhibition problem. Their cognitive processes, their language, everything was dampened. Okay? So when I talk about arousal issues, I'm talking about the high arousal kids. Okay? So there are a number of things that we look at for arousal. We look at activity level. So these are going to be the kids with the high activity level, right? Running around like little crazy people. We also want to look at the voice level. Oh, they got the high, shrill voices. You know, the kids you're always telling, inside voice, inside voice. You know those kids. Yeah. Yeah, so ideation is often seen with, well, no, let me put it this way. Poor tactile discrimination can contribute to poor ideation. Because think about babies. What do babies do? They manipulate everything, right? If they have poor tactile discrim, how do they learn about object properties? There's object affordances. They're getting imprecise sensory feedback, right? Okay? So we see problems with that. Not always. Not always. What I find is that a lot of the kids with ideational problems have flat affect. They do have flat affect. They don't always have low arousal. Okay? Some of them are quite the opposite. They actually can be really hyper because they're just zipping everywhere trying to kind of get to the next thing because they can't conceptualize what's next. So the impulse control activity level, I actually looked at behaviors in my kids with ideational issues, and they had a lot of impulsivity and a lot of distractibility. Okay? All right. So other kinds of things that we're looking at, respiration, short, shallow breathers, rapid breathing, things to look at there. We also want to look at those autonomic nervous system responses, the kids who get flushed. You know, the kids who've got the blown pupils, they look like they're on crack, right? All right. Oftentimes that's going to show you high arousal. Also looking at internal states. These are often children who are not hungry and then they're starving, or they're not tired and then they're exhausted. So we talk about interoceptive inputs. They often seem to have poor interoceptive awareness. Now, other things that we look at here is being able to filter out background noises or visual stimuli. That can be problematic for them. All right? The next thing that we want to look at is modulation. And with the modulation, we want to look at tactile, vestibular, auditory, and visual inputs. So what are we looking at for tactile modulation? These are things you're probably familiar with. Kiddos who get upset about light or unexpected touch. They're the ones that turn around and whack somebody when they get tapped on the shoulder, right? Or they have problems standing in line. I love these kids because they're the ones who are always outside of the line. You know, the line's over here and they're here. Or they're at the back of the line and the next kid is like 6 feet in front of them. So they're always the caboose. We also see these kids getting upset about imposed touch. They don't like hand over hand. They don't like other people putting their hands on them. They may get upset about it. Another thing we want to look at is touch of clothing. So they may be, you know, pulling at their clothes all the time. pushing sleeves up or down, all right? Being, you know, the traditional things, fussy about tags in shirts, waistbands, socks, you know the routine. Vestibularly, let's talk a minute about vestibular issues. Most of what we think of as vestibular modulation problems, we now think is actually a conflict of sensory input, and we actually think it's probably more of a discrimination problem. So gravitational insecurity, I now think of as a discrim issue. I have for years. Even some hypersensitivity to movement can be discrimination. Because what we have found is that, you know, you have 3 sets of semicircular canals. We find that if you test these children in 6 positions of PRN, you do upright, and then you do side lying, clockwise, counterclockwise, side lying the other way, clockwise, counterclockwise, 6 positions. We often find that they have prolonged nystagmus in some positions and decreased nystagmus in others. So think about how sensitive you would be to movement. If I move this way and my nervous system perceives this as being hyper-responsive, and it goes, ah! On the other hand, if I move this way, it's under-responsive, and I'm like, oh, and I'm falling over. So I'm moving in different ways, and my nervous system doesn't know if it's going to have an over-response or not. So I don't know where I am spatially. Does that make sense? Okay? So I'm not going to want to move, right? So a lot of gravitational insecurity falls in this area. I have put it under modulation because that's where everybody still puts it these days, but I want you to think about it differently. I do think that some movement that elicits autonomic nervous system responses, like getting car sick or air sick, you know, it makes you break out into sweats, flushing, those kind, heart rate, those are probably more likely to be a modulation-related issue, okay? So if we look at observations for this, these are things you could see in the class. The child gets dizzy on playground swings. Shouldn't get dizzy on playground swings, okay? Do they get nauseous or sick on the school bus, okay, or in the car? Are they fearful of having their head out of an upright position or moving their head in different directions? A big one that you might see is that these kids, you know, they go to get something under the desk and it's like this. All right, they don't want to put their heads down. Or what you may see is the teacher asks them to pick something up off of the ground and they will act up in order to avoid doing it. They'll act out. They'll, you know, be silly, maybe they'll get angry, maybe they'll run away. And it's a behavior problem. And the problem is they actually don't want to lean their head over. That's the problem, okay? So look for those behaviors around those kinds of situations. We may also out on the playground see them avoiding climbing or using playground equipment. These may be kids that never climb up on the jungle gym or go on the swing, and they just run around, all right? Another thing that we may see is that they get upset when the lights are turned off. If the teacher turns the light off or it gets dark in the room, they can get upset because they don't know where they are in space without vision, all right? And lastly, you might see them being fearful when they walk on uneven surfaces. So if the ground is bumpy or there's wood chips down on the playground or gravel or something like that, they may avoid walking on those kinds of surfaces. All right? The next thing we want to look at is auditory. So these are pretty familiar. for modulation. They get distracted. They cover their ears. They scream, perhaps at noises, right? Bells. I mean, we saw in the video there, that child was distracted, but he wasn't defensive, okay? Another thing that we will see that's important to look at for auditory defensiveness is kids that make vocalizations or humming, or they sub-vocalize and talk to themselves a lot. When you talk, it triggers an acoustic reflex in the inner ear that locks down these ossicles in your inner ear so that you don't blow your own eardrums out. You know how when you listen to a tape of yourself, you sound different than it does when you're talking? That's because you are hearing a muted version of your voice. Okay, yeah, because these little bones are being clamped down. So a child who is auditory defensive may make a lot of self-noise to keep that reflex tampened down so that they are then, in effect, dampening out the external noise. Okay? So for instance, I'm talking all day long. By the time I go home tonight, or go back to the room tonight, my ears are going to feel like they're plugged. All right? Because I'm going to have locked down my stapes and hammer and anvil. I'm going to have locked it down by the end of the day. When I first started teaching and lecturing, I would finish a course and I would actually have an earache. My ears would hurt. Okay? After way too many years, that doesn't generally happen anymore, but it did at first. Okay? So look for this. Another thing that will do the same thing is grinding your teeth. So if you see kids clenching, you know how they'll grind their teeth? Okay? If they're grinding their teeth, that clamping down of the jaw also triggers that same reflex. Okay? So you want to look for those behaviors. The last thing is visual. We may see them being distracted by the visual stimuli, those lights in particular. Okay, they may want to wear their hats in the classroom all the time, or they may put their head down and do their work like this, so they're actually closing out the visual stimuli. We may also see them wanting to wear sunglasses inside. Visual stimming is sometimes a result of visual overstimulation. You'll see kids with autism will sometimes do this out at the periphery, or they'll do this side-looking kind of behavior. What happens is when you do movement out here at the periphery, you know you have your rods and cones, your central and your peripheral vision. Your peripheral vision is triggered by movement. Yeah, it is keyed to movement for protection. So that's why somebody walks in the door and I'm facing you like this, my peripheral vision picks up on that movement. My arousal goes up and I alert to it because that might be a predator coming to get me. All right? And so if a child is overstimulated here at central vision, they'll stimulate this peripheral vision with movement as a way to help calm themselves down. Kind of cool, huh? And same thing with sort of that side eye. They may do the side eye to get that peripheral vision, or they may do it because they ocular motor-wise are not able to visually converge. Okay. Yep. It's the visual system. It's the visual system. For convergence, vestibular. Tactile doesn't have anything to do with the eyes. It's all vestibular and prop. It's the visual, vestibular, proprioceptive triad. If Mary Kawar, who's very well known for her vestibular visual work, always said, if you have a vestibular problem, you will have an ocular motor problem, a visual problem. And most of the time, if you have a visual problem, there will be a vestibular problem. Okay? They're that closely linked. All right? Okay, that's our modulation. Got it? All right. Next thing then, let's move into looking at the discrimination skills. Okay? So for discrimination, the big areas that we want to look at are tactile, prop, and vestibular, and then to a lesser degree, visual. All right? Because visual discrimination is important for ideation. If I don't have good visual discrim, can I recognize object properties? No. I'm not going to be able to discern object properties to develop affordance knowledge, right? Okay? So let's start with tactile discrim. Tactile discrimination is our foundation for motor planning. All right? It's our body scheme, our hand skills. So when we're looking at observations, we want to look at these areas. So are these kids who have problems responding to touch? You know, you tap them on the shoulder and they don't recognize that you've been touched. You've tapped them. All right? They don't recognize food or drool on their face or their hands. Another thing we see with these kids is they bang into things, they get bruises, they fall down, and they're oblivious. So they're often oblivious to pain. All right. I've had kids with poor tactile discrim who literally have shut their fingers in a car door and didn't even realize it. I mean, they're you know, they have a couple fingers here and they are completely black and blue. They're lucky they didn't break a bone, and they were totally oblivious that they'd slammed the door on their hand. Okay. Another thing we look at is that remember that tactile function is the foundation for hand skills. All right? So pencil grip, manipulation skills, grasping patterns. If those are decreased, you're going to have had poor tactile. Also looking at the kids who don't separate their finger movements very well. You know that their hands are like this. They just like hang off of the end of their arm, right? Their hands look like mittens because they're like this. That's a big sign of poor tactile discrimination, okay? And all of these things, you don't have to write them all down. They're all they're all on your form, okay? If you want to, that's great, but I just don't want you to feel like you have to scrabble to write them. You can write down the extra stuff that I'm telling you. All right, we talked about holding and manipulating objects. Another thing that you will see with this are behaviors like mouthing, okay? Chewing, biting, chewing on their hands. You may also see them needing to touch everything. These are often kids who don't keep their hands to themselves because they have to touch everything. Yeah, they play with the hair. Another big thing we see with these kids is they drag their hand along the wall when they walk down the hallway. Because if they aren't touching the wall, they don't know where they are in space. Okay? So they will often walk along and they drag their hand on the wall. So they're always getting in trouble for touching things and leaning on people. Okay? They lean on people a lot. Another thing that we see is they have problems with transitioning with flooring. So they may have problems going like a floor like this where there's two tones. You may see them have problems with that. Or especially if there's like carpet to tile, they'll trip on the transition strips. Okay? I'll tell you the big thing. This was an issue for me. So I have noticed that as I've traveled around, a lot of the bathrooms in other countries have a ledge, right? You don't have that in the US. Okay? Our bathrooms are just the floors are flat. I cannot tell you how many times I have tripped over the darn floor going into the bathroom. The house I moved into, we bought a house couple years ago. Our bathroom upstairs has a little ledge. Can I tell you how many times I have jammed my toes into that transition? Okay? So this is something that we see a lot of problems with. And I've been having a lot of difficulties with prope and tactile in my feet as I've aged. So I stumble on things a lot more than I used to. So that's something to look for. Another thing that you may see here is they don't use their hands or body parts without vision. So if, their feet might be doing things under the table, kicking and banging, and they are oblivious to it. They may also not like to have their arms under shields, or, you know how we might reach underneath here to get something, you feel around for it? They won't do that. Okay? All right. Now, proprioceptive discrimination. We're looking at observations of forced body position, all right, muscle movement, muscle contraction. So things that we're looking for here, again, poor awareness of food in the mouth. These kids often pocket food. Food falls out of their mouth when they eat, or after they're done eating, they still have food stuck in their cheeks or on the roof of their mouth. They may have problems climbing on or off of playground equipment. When they go to get something under their desk, they whack their heads because they don't know where their heads are. When these kids move, they look stiff and rigid. They do not move fluidly. And we also see them having a lot of problems with backspace. So what I've seen with these kids, first of all, they don't want to move backwards like that, step backwards. That's hard. When things are behind them, it's gone. If they drop something down and it's behind them, it might as well not exist. Because anything that's back here doesn't exist anymore. Okay? So this idea of backspace, out of vision, is poor. Another thing that we see is that they have problems with stairs. They might not put their foot in a good position on the steps. They might trip or fall or stumble on steps off of curbs. All right? We may see that they have problems with slow, controlled movements. These kids they're often moving fast. And you can't get them to slow down. You get them to stop and slow down and they fall apart. All right? They're often little, thin, wiry kids, all right, that are like little monkeys because they're zipping around all the time. This is because they're using their large postural muscles to stabilize because they have such poor prope that their small tonic muscles don't work well. All right? Another thing we see is force. They use too much force. They're the kid who always comes up and says, "Hi!" Whack, 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 whack. Right? They're breaking pencils, they're snapping things, they're knocking things over. Yeah, they're clapping and hitting way too hard, right? They make a mess at mealtime because they're knocking the glass over, all right? Or the food is all over the place. We also see them needing to move a lot in their seat. They like to stand, all right? If they're sitting in a chair, they're on the edge of the chair like our Ethan was, okay? They're moving around, they're kicking the feet. They have to be in constant movement or they're not getting proprioceptive feedback. Or we find them hanging on things. My son had some proprioceptive challenges as a kid. He had that little bit low tone, you know. It wasn't awful, but it was just enough. That kid loved to hang on the banisters on our stairs. He broke the brackets for my banisters twice. We had to replace them because he would just hang. Even at 2, I've got a picture of him hanging on the wall. There was a little lip on the wall, and he would hang on the wall with his hands and legs. You know what he did as an adult? He became a Marine. He was in the Marines for 8 years, and now he's a federal police officer. So, you know, he found a job that gave him all that heavy work that he needs. Other things that we see is these are kids who have problems navigating around the classroom. They're always banging into people, bumping into the desks, knocking things over. They crash into the doorways as they go through the door jams, all right? All of these are signs of poor prop. All right? The next thing then is vestibular. And vestibular functioning, these are the kids who don't like to be tipped backwards, don't want their head back. They don't know where their head is in space. These are kids who go to lean over and they fall over. Because as soon as that head starts to tip, they can't discriminate between here, and boom, they're on the ground. So these kids get in trouble a lot for falling out of their chair, when in fact it's because they don't know where they are. They also don't know about direction and speed of movement. So when they're out on the playground, they're often crashing into other children, all right? They often have problems changing direction. So they're running along and they're supposed to change like this, and you see them overshooting and having to come back or needing to stop in order to turn. All right? They're not able to do that kind of navigation very easily. Another thing that we see is poor balance. All right? So narrow surfaces, uneven surfaces are problematic. If you do see them on swings, merry-go-rounds, moving surfaces, they fall over. That's it. All right? Also, they're not safe. They often are bumping into people, crashing into things. These are the kids that are walking down the side of the street, and the next thing you know, they're in the middle of the street. You know, you never let them on the street side. All right. I've given you here also a few observations for visual. And oh, I threw an auditory in there. I forgot to put on the questionnaire. But really looking at, can they visually, for instance, can they locate items? If something's behind something else, can they find it? Can they use their eyes and hands together? Or are they having to really visually monitor what they're doing? Another thing we will see with kids with poor visual discrim is swiping, clearing, and dumping things, because they can't isolate a single item amongst an array of things, so they'll sweep it all away. So kids that are often doing that clearing behavior, especially autistic kids, it may be poor visual description. Okay? All right, that's our discrimination. The next thing we want to look at is posture. Okay? So looking at postural foundations, we're looking here at muscle tone and stability. Look for joint hyperextension. I've given you in your form a few ocular motor things, okay? Posturally, we also want to look at posturing the arms. Do the arms go like this when they're jumping up and down? All right, or are they doing this when they're jumping? Do we see protective responses or not when they are knocked over or bumped by other people? Or are they falling over? What about equilibrium and righting reactions when they're leaning or falling? Transitional movements. Is this a kid who's sitting down during circle time and has to get on his hands and knees in order to stand up? And then what about trunk rotation? Is this a kid who's using trunk rotation to reach for things? Is he doing this lateral weight shifting to lean down, pick things up? Look for those postural activities. Can they sit independently, or do they, like Evan did, do they have to prop themselves up on the table? Okay. And then if they're sitting, are they using that wide W sit? Or even like a big ring base of support? Okay, are they really needing to give themselves a big base of support? Now, there's a lot of postural observations. So looking at things like weight shifting in their seat, can they weight bear in quadruped? Can they crawl? Can they stand? Or do they always stand using a wide base of support? What about needing an external support to maintain their position? Do they walk with a high guard? Do they stumble and fall a lot? What about toe walking? Right? That's a biggie. And when they're walking, do they use a reciprocal arm swing? Okay? Or is it, this thing? Right? The stiff, rigid little guys. All right. That brings us then to bilateral integration skills. Because remember, those belong with part of our postural ocular movement issues. So what we see here are a lot of associated movements. We see the tongue sticking out, right? Especially with effort. Do you see when they're writing, is this opposite hand clenching? Do they clench their hand, or is it moving when they're writing? Okay, those kinds of associated reactions. Do we see them having problems crossing the midline? Now, let me tell you a trick about an important point about crossing the midline and trunk rotation. If you do not have trunk rotation, okay, you cannot have crossing the midline. So if you're looking at this child and they are not crossing the midline, the first thing you have to look at is whether or not they are trunk rotation. If there's no trunk rotation, the problem is a trunk rotation issue, not a crossing the midline issue. Okay? That's important. Another important thing about crossing the midline is this is not your midline. This is your midline. This is my midline. I can work here with no trunk rotation. As soon as I move past my shoulder, I have to rotate. See that? Okay, that's really important because a lot of our kids are doing their schoolwork here. So you may not see whether or not there's actually a crossing the midline or a trunk rotation issue unless they have to reach something. Most of us who are right-handed, if something is close, we'll rotate and use our right hand to reach it rather than use our left. So if you're seeing these kids never reach over and rotate, they probably don't have trunk rotation. Okay? So make sure you make that distinction. Another thing you want to look at is, are they segmenting trunk from pelvis, shoulder from trunk, and head from shoulders? All right? Does that head rotate off of the, are they turning the whole body? Another thing is, are they transferring objects hand to hand? Do they do that transfer? Are they able to hold things in both hands simultaneously? Or do they have to support themselves and only use one hand at a time? Okay? Those are some of the bilateral integration things that we see. You're looking at your laterality, your handedness. I didn't include any handedness items in here, but that is definitely something to look at is, is there established dominance or not? Okay. In your notes, it says execution and feedback. I put that there because that's a motor control issue. We're going to talk about that later, all right? And it fit here, formatting-wise. So that's why that's there. So we'll come back to those few observations. Okay. It is almost lunchtime. So I think what we will do is we're going to finish gross and fine motor skills, and then when we come back from lunch, we'll go over postural control, or we'll get into the praxis. Okay? All right. Observations of gross and fine motor skills. Clearly, many of these things tell us about motor planning. They tell us about bilateral coordination. They can tell us about projective actions. I separated them out only because sometimes in the schools they want fine and gross motor skills separately, all right? So I just kind of separated them out. So things that you want to look for that can inform you about praxis skills. Can that child squat down and play? Can they play while they're squatting down like that? Do they walk backwards, sideways, on their tippy toes? Can they walk with their feet in a line, do the line? Can they run forward and change directions with good control? Can they run around obstacles without crashing into things? Can they run? When they run, do they look weird? Okay? I don't know a better way to say it. You know who I mean, right? The arms are flapping. Or do they have good reciprocal movements? What about jumping? Jumping is a biggie. Can they get their feet off of the ground when they jump? Right? Can they jump up and down, getting over something? A lot of our kids can kind of get off of the ground but can't clear even a small object, right? And what about jumping down off of things? How many of your kids do that? They can't jump with both feet, all right? So these would be things that you want to look at. Now, hopping on one foot. Not only how many times do they hop, but can they hop with control? What I usually will do is take one of the tiles that's on the floor. Tiles are usually like 10 or 12 inches square. And I say, stay in the square. And I want them to hop up and down on each foot 10 times. Are they all over the place? Are they spinning around? What kind of control do they have? Throwing a ball. Can they throw it with accuracy in terms of direction? Can they catch it with both hands? Can they catch a small ball and a large ball, or only the large ball? What about kicking balls? Do they have to have the ball stationary, or can they kick a rolling ball? Do they only kick it if the ball is coming directly at them, or can you roll the ball to the side and they'll kick it stepping to the side? Okay. What about reaching for things in terms of fine motor? Can they reach accurately? Yeah, a lot of our kids can't, can they? Oh, and they're fumbling, picking things up. Can they change their hand shape as they prepare to pick up objects? So for instance, if I pick up this, my hand should look like this, right? On the other hand, if I'm picking up my phone, it's going to be like this. Or if I pick up a pencil, I should prepare to pick it like this. So I should mold the shape of my hand in anticipation of picking things up. So we're looking at that anticipation. I also want to see a variety of grasping patterns, or is everything like this, right? Can they carry objects in their hands? You know, if I give them 2 or 3 objects, can they hold multiple objects in their hands at the same time? And then what about isolating their thumb movement for writing, holding things, right? Or do they have to hold things against their body to manipulate them? All right? And can they accurately release things into small spaces? What's their precision like? All right? Okay. Phew! Is your brain a little fried at the moment? Lots of things to think about, isn't it? All right? Okay, what we're going to do is we're going to stop for lunch, okay? Be on time coming back because we're running really late today. All right, 2:30, come back for lunch and we'll finish up the praxis, and then we'll get into some of the reasoning pieces and interpretation.
Thank you for a most interesting, engaging session, ma'am, focusing on the assessment of praxis, clinical observations of modulation, discrimination, and postural foundation. So I would now like to request all the dignitaries and the professional delegates to have your lunch, which is being served opposite our auditorium in demo room, and kindly get back to your seats within 30 minutes. By
2:30.
By 2:30. And there is an announcement need to be done. Someone among the delegates has left your phone during your breakfast, which is Redmi. If it is anyone's phone, come and collect it here.
Oh, I'm surprised somebody's not looking for that. Oh, let me take the mic off. Much better. Okay.
Is this your phone? Respected delegates, kindly take your seats. We are going to move on to the third session titled on Interpreting Praxis Assessment and Clinical Reasoning for Intervention. On to ma'am.
I got it. Just have to get it together. It's not good. I do this a lot. Okay. One minute before we get started. Hmm? Nope, I'm good. I just needed a painkiller. All right. Welcome back. All right, we are going to move into observations of praxis. And then I promise I have videos and things for you, okay? So this is just the less fun part of the course. Well, I don't know. I think it's fun. It's just not as exciting, right? Okay. Let's start talking about ideation and what you're going to look for in terms of observations. First of all, kids with ideational problems have difficulty initiating activity, all right? They often can sit back and kind of wait to do things. If they do initiate activities, it tends to be pretty consistent. They don't tend to vary their play very much. If you ask the parents or the teacher, what does the child do on the playground? What do they do? You know, what do they play with? They will usually indicate one or two different things. All right, they don't tend to have a very wide repertoire of interests. We also see them having what appear to be memory difficulties. That you ask them, what did you do earlier today? I don't know. What did you do yesterday? I don't know. All right. So they appear not to be able to remember things that they've done in the past. However, if you give them choices, did you do this or did you do this? Then they frequently will recall what they did. The problem seems to be not being able to pull the information out, okay? Another thing that we see is that their language that they use is very concrete. These kids do not like to do pretend play, and they don't want you to do any representation of things. So no nicknames. You know, you might say, hey, honey, you know, sweetie. No, don't call me sweetie. All right. They also, things are very literal and concrete. It's not a car, it's a bolster swing. Okay. So they're very specific about this, and they can get quite upset. They may play with a very restricted play theme. So, for instance, they might say, they might play maybe Star Wars, but that's it. Nothing else. Or they'll do, you know, Thomas the Tank Engine or whatever is popular at the time. but that's the only thing that they'll play, all right? So they can be very specific. Another thing that we see is that when you give them something new, they don't know what to do with it. They may bang it, try to break it, throw it, but they don't really know how to manipulate it, all right? Or they may use actions on that object that's within their small repertoire, okay? Usually these are the kids where if you ask the teacher or the parent, what do they do with a new toy? They'll rattle off 3 or 4 actions. Pardon me. Another big thing that we see with them is that they use inappropriate actions with objects. These are the kids who are throwing things that they shouldn't throw. They are standing on things that are unsafe or that they're not supposed to stand on, okay? So they don't seem to get what objects should be used for, and they will use them inappropriately. So ideation is not a matter of not having ideas or never knowing what to do with things. It's really more a matter of not having very many ideas, all right, and not being flexible with their ideas. It's really a matter of quantity. Now, for motor planning, we see these kids having problems with imitation, all right? They have problems with, like, in gym class, learning how to do new activities. In class, they might have problems doing group actions. So like maybe they're doing a group activity. Everybody's supposed to, do like Simon Says or something like that. And they will have problems following along. We also see them having difficulty using those tools like scissors, rulers. They have problems manipulating their body. So, for instance, if they're supposed to like swing a hoop on their arm, you see their body, their arm is like going up and down instead of around and round. We also see them having problems setting up the environment. So these are the kids that when the teacher says, bring your chair over to circle, they're like, banging the chair on the desk and having problems moving it. They don't put it in the right spot, all right? In the clinic, they don't set up equipment. They don't know how to set things up accurately or where to put it. We also see them having problems with construction. So when other children are able to cut things out, fold it, paste it, to make, all those cutesy little boxes and things that they always have for kids, our kids have problems with those kinds of constructional activities. We also see them having problems being effective. Sometimes these kids will come up with plans, but those plans don't work, all right? And they miss pieces, like glaring pieces or steps that need to happen. Another big thing that we see with them is that they don't recognize feedback of their actions. So they do something and they don't realize that it's not working, and they don't change what they're doing. So they tend to do the same things over and over again without changing it. And then they get frustrated because it doesn't work. Okay, shh. Another big thing that we see is that they have problems with sequences of activities. So especially activities that require shh. Okay. Guys, can I have you shh? Okay, I can't speak over you at this point. I know it's hard after lunch. It was a short, quick break. All right. So having problems with sequences of activities. So things that require multiple steps, they may not remember the steps. They may mix them up. They might, what we often find is that when they're told to do several steps, they will do the last one or two and forget the first ones. Okay? The other thing we see with motor planning is that the quality with which they do things. They fumble with things a lot. So like we saw our little guy trying to use the scissors. What did he do? He turned him around. He had problems orienting the scissors and figuring out how to get his hands in it. So any of those kinds of things where they don't really figure out what to do with their bodies and how to use their bodies with materials are going to be big red flags. Okay. The next thing then is bilateral motor coordination. These are going to be all of those activities where they're using two parts of their body. So, this might be pumping a swing out on the playground. It might be playing games in gym class, like tetherball, where they have to hit the ball. Okay, can they hit it with two hands? What about even something as simple as clapping their hands? Are they splaying their fingers when they clap their hands? Okay. Are they able to actually use both hands to carry things effectively? Or, is it tipping? All right. Can they keep it level? Like when they're carrying their tray at lunch, are they trying to do it with one hand? Are they able to use two hands together? Another thing is look also not just at what the arms are doing, but what the legs are doing. We also want to look at bilateral skills in the lower extremity. So can they jump down off of things with both feet together, or is it one of those kinds of deals? Can they jump up and down, or is it, like this all the time? Another thing is, can they alternate their feet going up and down stairs? Or is it, the chop, chop, chop kind of thing? And then looking at how do they use both hands to manipulate objects. Can they hold and stabilize something like a paper and cut? Can they orient something with one hand and manipulate with the other? The bot is a really good test for this. So things like stringing the beads or putting those pennies in, those are great activities to look for bilateral skill. All right. Here's another list of a variety of bilateral activities that are easy to observe. Hopscotch, buttoning, shoe tying, any kind of functional skill, like even opening their backpack. Can they hold it and pull and open it? Riding a bike, hopping on one foot, and doing those things like the jumping jacks or the straight jumps. All right, then we have projected action sequences. Let's talk about these a little bit, because I think this is something people are less familiar with. Projected action sequences are get ready responses, getting the body ready. So one of the things you want to really look for is, does that child prepare for action? So if you're going to toss the ball, do they just stand there? Right? Or do they get their hands up and ready to catch? And are the hands oriented appropriately to catch the ball? What about if they're going to throw? If you're going to roll a ball to somebody, you or I would weight shift and get ready to kick. All right? So we want to look at that preparatory action. What about doing hopscotch? I'm going to get my body ready to jump. All right? So do they do that postural readiness. The other thing we want to look at is how do they move through space? So do I make that shift to kick the ball? Can I run across a field to be in the right place at the right time to kick the soccer ball? In the US, it would be to catch a baseball, okay? Maybe a cricket ball, okay? So look at those spatial things. Another thing that we want to look at is projected actions with the feed forward mechanisms is what allows us to repeat things quickly without having to pause or stop, okay? So one of the things you want to look for is whether or not kids will repeat things 4 or 5 times in a row. Oftentimes you will find these kids do something once, they'll do it twice, the third time they're done. All right? So you might see them like jump in the boxes and you'll see 1, 2, and they'll stop, and then it's 3, and then it's 4. I don't get those 4 jumps in a row without stopping. Does that make sense? Okay? It can be hard to look for, but really watch for this because that feed forward, that anticipation of action is really important. And it's something these kids have huge problems with. Another thing is that we often see them having problems with sequences of actions. So, for instance, running up and kicking a ball is hard. They'll run up and then they'll stop and kick. So they'll segment those sequences. All right? Another thing that we're looking for in these kids is how they navigate through space. Can they navigate around the classroom? All right, so that's a stationary environment and they're moving. Another big thing we see with these guys is safety. So out on the playground, kids are running around, they can't avoid the other kids, or they run around and they're crashing into other children. Crossing the street is probably one of the biggest problems. These kids are often oblivious of the timing of the cars coming towards them and where they need to be in space as they cross the street. You can see this in any sports types activities as well. And then lastly, any kinds of ball skills. All right, any kinds of ball skills are going to give you an idea about projected actions. Another thing that we see here is in school is they have difficulty staying in line. So you know how when you're walking in line, everybody kind of keeps a certain distance from each other, and the spacing kind of between the kids is about the same, mostly. Our kids are the ones who are too slow, too fast, out of line. All right, they are not able to walk with others. So we see them having problems even with a teacher or another child staying in unison with someone, staying together with them. They're the ones who are always, dragging behind or running ahead. You know those kids, right? They have problems with them. Another thing that we see with them is that if you're in a clinic and they're on a swing, they might have problems taking a beanbag from you or leaning over to pick up a beanbag where they're moving and the beanbag is stationary. Obstacle courses and navigating all of the body changes and the sequencing of obstacle courses are problematic. So these kids tend to have a big problem keeping up in gym class because gym class is all about projected action sequences. So they get into a lot of trouble because they're always behind, they're not following directions, they're not getting the right sequence, any of those things. Another thing that we see is playing chase or tag games. can be hard for them. And then we talked about the safety of avoiding swings and playground equipment. All right. Those are our biggies for our praxis. Now, a couple other pieces. Feedback. Remember I said we'd come back to the feedback a page or two back? So for feedback, these are the kids who don't recognize what they just did. So you do something with them and you're like, what did you just do? Well, I don't know. They have no idea. Okay? Another thing we find out for them is that they might do something successfully, but we ask them then to repeat it, do it again, and they can't do it because they have no idea how they did it in the first place. Okay? Another thing is that these kids often are oblivious to their impact on the environment and other people around them. So the other kids are playing ball, right? And our kid is right in the middle of it. And they're oblivious. And what happens then? The other kids are like, get out of the way, you're in our way, stop interfering, move it. What's going on, right? And so we talked about praxis impacting social, right? This is a big example of how the praxis problems impact on the social difficulties. Because is that going to be a big social problem? Yeah. All right, we're going to see a big issue with that. Another thing we see is that these kids fling things, they throw things a lot because they're not getting feedback about the impact of their actions. And often they're really unsafe. I mean, they're throwing hard things at windows or where other people are. And they do often get in trouble because they hit Sally because they threw a block at her. And they didn't mean to hurt Sally, but they just wanted to get rid of that block and they whipped it and were totally oblivious that Sally was in the way. And that's sometimes what they'll say, well, she was in the way. You know, they don't get that impact. Another big thing that we see is that these kids will knock over other children's play structures. They will destroy other children's work without being aware of it. You know, these are the kids who put the books down on top of somebody's little box that they made, or they stack things on it, or they sit on it, or whatever, because they're just like oblivious that she might be upset that this thing that they worked on so hard is now destroyed. Okay. All right. The next thing is a few things around organization of behavior. So think about organization of behavior around activities and routines. So these are kids who don't move from one thing to the next in a logical manner. These are the kids who just kind of flip from thing to thing. Oh, let's do this. Oh, let's do that. Oh, let's do that. You know, it's like they see something and they're off to it without stopping to think about it first. All right. We also see them having problems with that functional sequence of ADLs. This is very common for these kids to, you know, put their pants on before they put their underwear on, or something like that, where they're mixing up the normal sequence of doing things. And any kind of multi-step activity is problematic. Another big thing that we see are school-related activities is getting ready to go to school or leave school to go home. So when you get ready to leave school, what do you have to do? You have to get your homework together. You have to put the papers in your backpack, right? You have to get your jacket, maybe put shoes on, right? There's this whole you have to line up, and there's this whole sequence of things that has to happen. What happens to our kids? They're mixed up, they're late, they forget things, right? So they mix up the sequences. Within the classroom, we've already talked about these kids having problems organizing their belongings. Their desks are a mess. Papers are everywhere. They can't find things that they need. All right, you know this kid, right? Another thing that we hear at home is that they have problems with homework routines. These are kids who don't really get how to approach doing homework, you know? Transitioning from watching TV to sitting down to doing homework, to looking at, here are the 5 things I need to do for homework tonight. Which one do I do first? You know, which one do I do second? And what do I need to use to do this particular homework assignment? And then oftentimes finding they left the book at school, right? And then that translates not only into homework routines, but into daily schedules. So as these kids get a little bit older and need to be more responsible, they have problems with morning routine, right? Getting dressed and showered and have breakfast and get things ready to go out the door in order to get to school on time. Those overall daily schedule kinds of activities are problematic for these kids. Okay. All right, the last thing I wanted to talk about in terms of observations is problem solving, okay? Looking at what are observations about whether or not a child is able to take those practicabilities into that next level of being able to recognize feedback, come up with alternatives, and make changes to situations. So first of all, these kids oftentimes are unable to identify that there's a problem in the first place. So they might be stuck on a particular component of an assignment, but they just know that they might not even know that it's not working. Sometimes they do, sometimes they don't. But they're not able to tell that there's a problem that needs to be solved. All right? They'll just be like, oh yeah. So a good example of this is they're trying to stack up blocks into a tower, and the blocks keep falling, and they just keep going, totally oblivious that, you know, they're trying to put big blocks on top of little blocks. And you're like, well, maybe you should try something. No, try something else. And they're like, no, it's fine. I can do it. And they just keep doing it the same way. All right? So this idea of not recognizing a problem. And similar to that, not being able to recognize that a plan is not working. Okay? Another thing is sometimes they will come up with plans that are totally unworkable. And they are bound and determined that they're going to try that plan. A big example I see with this is the kids in the clinic who want to swing on the trapeze from here to there. Okay? You know, like across the room. And you're like, do you think that's going to work? Oh, yeah, that'll work. And they swing and they land, of course, here. And you're like, I don't know if you got where you want it. I'll do it again. I can do it. They're totally oblivious that swing, there's no way that they could possibly swing that far, right? And so this often plays out into lots of other areas as well. Okay, another thing that we see is they don't use environmental cues, all right, to identify problems. Sorry, I'm going to need to get some tea. Oh, no. Sorry, they gave me hot water, but didn't put the tea bag in the water. So I get to do that. Okay. We got it. Let that brew for a minute. All right. Sorry, my throat's getting a little raspy, so All right, so things that we want to look at here is they aren't able to like look at this object and say, oh, how do I open this? You know, do I pull this off? Do I twist it? How do we know? Again, it gets back to this idea of recognizing affordances. How do you know that you twist these kinds of lids? Because there's this little crease, right? Yeah, there's this little ring, and there's a crease here. And when you see that, we know that those are twist tops. It's not a pop top. On the other hand, if it was all one piece and there's a little rim closer to the top and there's a little bump, then that tells us it's a pop top, right? We are using those perceptual object cues to identify what to do. All right? Our kids don't do that. And therefore, they can't solve problems. So what we have to do is we have to bring their attention to those objects, to those perceptual cues. All right? And point it out and say, I think there's a line here. What do you think that means? Does that mean you should twist it or pop it off? Okay? Another thing that we do, we see with these kids, is they always use the same strategy. All right? Whenever there's a problem, what do? Maybe they bang it. Maybe they always try to twist it or pull it off. Doesn't matter what the object is. They always use the same strategies on it. And then when that strategy doesn't work, they're not able to change their strategy. All right? So these are things that you can observe during their everyday activities in the classroom. Okay? All right, last thing that we look at with these guys, they're often really resistant to new ways of doing things because they cannot do the problem solving and the motor planning to do it a different way. If they do try something, it might be trial and error. It's not systematic. There's not a rational step-by-step process of how to do something. And a lot of times they will often say, I can't do it, before they try to solve a problem. All right, so often, or they may go to the teacher as soon as they realize it's not working, and they won't even attempt to do it themselves. All right, so that's our problem solving. Last thing I wanted to mention about this is the scoring on this measure. So you'll notice here that the beginning areas are just, is it there or not? Is it observed or not? Most of these behaviors are things, well, you have to look at whether or not it's a behavior that's a positive behavior or a negative behavior. For modulation, you're going to identify, does the child demonstrate an over-responsive or a defensive reaction, a shutdown or overload response, or an appropriate response? Some of the questions are worded as negatives, and if it's a negative question, you're still going to score it that their response was defensive, overload, or not, okay? I mean, if the question is they dislike light touch, that's a defensive response. Does that make sense? Okay. Then for the rest of the items, all of the rest of the items have not a problem, a mild difficulty, oh, thank you. Thank you very much. A mild difficulty, a moderate difficulty, or a definite difficulty. So part of the question is, how do we identify that? Okay. Oh, it needs to be way heavier, thicker than that. Throw another pot. Okay. So obviously, if the thing that's indicated is not a problem, maybe the question is that they don't alternate feet on the steps, but they do. That's not a problem, right? What's a mild, moderate, or definite difficulty? basically, you are going to set your definition by your population. A mild difficulty is basically, you know it's not quite right, all right? But it's not a huge deal. It's like a little bit of an issue. A moderate issue is something that's pretty noticeable, but not the worst thing in the world you've ever seen. And a definite difficulty is like, you're like, oh boy. Okay? So, if we look at our little guy from this morning, what would we score his working on the scissors? Doing the scissors. What would we give him for that? Definite, I would give him a definite. He did it, but how did he do it? Was it easy or was it really pretty hard? It was pretty hard. So if you look at the range of, this is not a problem, to he definitely had problems orienting those scissors, it's a definite difficulty, right? So I'd give him a definite difficulty. Because if you say some problems, then that means that sometimes he might be able to do it, and I don't think he ever would. Now, what if we have a child going down the stairs, and he alternates his feet 3 out of 4 steps? What would we maybe give that one? That one I might be some difficulty, because he's doing it right more often than not. Okay? Or a moderate difficulty. Does that make sense? That's the way I conceptualize it. No, because remember, praxis is not about can you do it or not do it. It's about quality. So I might give you a quantification marker and be like, oh, 3 out of 5 times or something like that. But you don't see, you're observing them in the school. And you only see that particular behavior. We only saw 1 scissors, right? How are you going to quantify him putting those scissors on, right? But there's definitely a qualitative problem with how he did it. Does that make sense? Maybe one of these days I'll get it more quantified. But it's really not so much about quantity. It's really about quality. And so that's why from an observational assessment, we're really looking more at quality with which they do it. Okay, and the quantity is more how many things in that section did they get wrong or did they have problems with. So if you've got the motor planning section and there's 15 items and he's got moderate to definite problems in 10 out of the 15, does he have a problem in that area? Yeah. What if he only has problems in 3 areas? Mild. Do you see? So the quantity comes more around how many of the items he has problems with. All right, does that make sense? All right, are there any questions about any of those observations? Mm-hmm. Oh, the reality is you probably won't see every single thing, okay? You probably will only need to identify 5 or 6 items for most sections to know, yeah, this kid has got problems in this area. Remember, we're using this largely in the schools. I think if you do an hour observation, or even a good solid 30, 40 minutes observation, you probably could see enough to identify problems in all of those areas. I mean, let's just take our little guy as an example. We watched that first clip for about 2 or 3 minutes. It wasn't very long at all, was it? And could you go through this questionnaire and fill out most of those items? Most of them. Not all, but could you fill out enough to identify that he had problems in most of those areas? Yeah, so it doesn't always have to take very long. And that's the great thing about this. Remember, this is an observational assessment. It's not a standardized test. It's a way to organize your observations, they're probably things that you often subconsciously picked up on, but maybe didn't quite articulate. This way, it makes you articulate your observations. So when you go to write your reports, you've got specific examples of what the problems are. And it gives you specific data about what areas are particularly problematic or not problematic. Does that make sense? Okay, great questions. Any other questions about that? Yep. Mm-hmm. Yes. It will go into both. It will go into both. Part of it you will be able to identify better in the moment what's going on. Secondly, remember, especially if it's a sensory piece, that sensory piece may be the foundation for that praxis piece. Okay? And remember, many items are going to be subcomponents of more than one aspect of praxis. So what it gets back to is the next piece is how do we make sense of some of this in terms of you have to look at patterns. What if you look at it and you only have a couple things in ideation, but you, let's say, have a lot of things under organization? What is the bigger problem? Is the bigger problem likely to be an ideational issue or an organization of behavior issue? It's likely to be an organization of behavior issue. Does that, maybe the ideation is contributing to it, but it may or may not be the bigger problem. All right, does that make sense? Okay, great question. All right, now we're ready for starting to think about interpretation and reasoning. Okay. First of all, this model is in your appendix. Page 2 in your appendix there. All right, what I want to do with this is a model that I use and that I use this in a variety of courses that I teach. And I often recommend that therapists use this with students and parents as a way to kind of show the relationship between some of these skills. So I find it helpful as a teaching tool for you to help look at how these things relate to each other. Okay? So this is how this works. This is going to be the tricky part. Hold on. Hello, where's my mousey? Hello, mouse. There you are. Okay. We'll use the highlighter. Oh, I don't want red. Yellow. I want red. Okay. The way that this works, we start down here at the bottom. All right. Ooh, this is going to be the fun part. There's the praxis. All right. The sensory processing. All right. We start with our various sensory systems, right? With our sensory systems, we do two things. We modulate them, right? And what else do we do? We discriminate them. I asked a question, I heard one response. Sing out. What do we do with it? That's much better. Thank you. We have a lot of students here, and you students, I asked how many people were students, and nobody raised their hands. And then Dr. Sankar tells me, well, about 45% of the people here are students. Shame on you. Don't be shy. I don't bite. I might tease you a little bit, but I won't bite you. Okay, so sing out. Discrimination. So we do two things. All right. The next thing we do is these sensory inputs are going to contribute to what we call foundational processes. And our foundational processes are going to be our postural, respiratory functions, auditory processing and language, visual, ocular motor control, oral motor control, right? All of those postural, ocular related kind of foundations. We have to have those in order to move, right? You have to have good postural stability and postural control. You have to have ocular motor control in order to do all of our praxis activities. Now, from a treatment perspective, these foundational processes can be addressed in a lot of different ways. Oral motor, we might do oral motor feeding activities, right? Ocular motor, we might do vision therapy. We might do NDT for posture, or craniosacral, or myofascial release, all right? Any of those kinds of issues. We might do sound therapy programs for the auditory. So we might address those in many ways above and beyond sensory integration. Now, our modulation is going to lead predominantly, not exclusively, but predominantly, to arousal, self-regulation, and behavior issue concerns, right? Our discrimination feeds into adaptive responses, praxis, and skill. All right? Now, in order for us to have organized behavior, we have to have our arousal and our praxis have to be in line, right? They have to be in balance. And when those two things are in balance, we are able to engage in functional occupations. Now, what happens if arousal level goes up? What happens to your functional occupations? It crashes, right? It slides off the top and it crashes. What if my praxis demand is too high? What happens to functional behavior? It crashes. Right, it crashes. How do we get them balanced again? We're going to use modulation and discrimination of inputs. So I see this as like being like a parachute, right? So if praxis is too hard, what do? We give some discrim and we balance it out. If modulation is a problem, we give inputs to that and we balance it out. So we tug on the lines of our sensory stimuli to balance out our organization of behavior. Does that make sense? Okay. Now, in the middle, there's this other stuff, right? So what do we have here? We have rhythmicity and sequencing and spatial temporal adaptation. These functions are cerebellar. What does your cerebellum do in terms of praxis and motor? It is a rhythm generator and our sequence generator. Okay? So praxis, our cerebellum, organizes our sequencing. Now, why do I have different things here? Let's take a look here. First of all, we have rhythmicity. And then we have sequencing. And notice how they overlap. Why do they overlap? They overlap because rhythmicity is nothing more than a predictable sequence. Okay? Usually it's short. Rhythms don't tend to be very long, but they're predictable and they're repetitious. On the other hand, sequencing, especially for discrimination, we could sequence a 7-step obstacle course. There would be no rhythm to that. Does that make sense? So sequencing is really important for praxis. And discrimination is how we develop sequencing. Now, let's talk about rhythmicity. I break this out because what do you do if you have a crying baby? What am I doing? Rhythm, right? Rhythm. We use rhythm to regulate arousal. On the other hand, when arousal's out of line, what happens to your rhythm? It falls apart. Okay? So rhythmicity has its relationship with modulation, and if it's a problem, it can impact arousal, but if it's good, we use rhythmicity to regulate arousal. Okay? So what's nice here is that rhythmicity and sequencing are like secondary lines on our parachute that we can use to balance out our organized behavior. Does that make sense? Is that cool? Okay. Now, rhythmicity and sequencing together form our ability to have spatial temporal adaptation. Okay? What's spatial temporal adaptation? It's knowing where you are in time and space. Okay? We perceive all sensory stimuli by how quickly, the timing, the rhythm, the sequence that it occurs. All right? So our spatial temporal adaptation then ultimately is our foundation, our balancing point for organization of behavior. So it's the base for our tip. Okay? So this is a framework. So when you're thinking about your assessment results, let's go back to the assessment results. You did your observations, right? You're going to look at this and go, okay, what's going on with the sensory? What's going on with maybe some of the foundational things? What's happening with modulation and how is that impacting arousal and self-regulation? How is discrim impacting those various components of praxis? Is there a sequencing challenge? And how are those two things impacting on this child's ability to be organized and to engage in those functional behaviors necessary for the classroom? Does that make sense? Does that help you organize your thinking a little bit? Okay? Excellent. That's what we want. All right. The next thing I want to talk about then is thinking about translating our assessment information into intervention. This is our first step. Okay? Oops, and you know what I need to do? I need to come back here. There's my arrow. There we go. All right. So, it's now time to start thinking about intervention. First thing, we're in the schools, right? Oh, thanks. I think there's T in here already. You're in the schools. First thing you have to do as you start thinking about intervention is what is your role? Okay, you're an occupational therapist, yes. But in the school system, we often play a unique role. We're often part of a team that is addressing bigger problems with our school children. You might only be one service provider amongst 5 or 6. Well, okay, maybe not quite that many, but at least 3 or 4, right? Especially if we're dealing with kids on the spectrum. So also, you want to think about who are your clients, all right? Are you working predominantly with children with cerebral palsy? Are you working with kids with intellectual disabilities, autism, learning disabilities? Because how you interpret information with a child with general learning issues versus intellectual disabilities is going to be a little different, isn't it? You're going to consider things worse. The same behavior will be worse in the child with learning issues than it will be in a child with intellectual disability, right? So you're going to have to think about who your clients are. The next thing you want to look at is what are the treatment models that are appropriate for you to use in that setting, because it can vary a lot. So for instance, do you have a treatment room and you're able to do pull-out services and take that child into a therapy room to work with them? Are you able to pull the child out, but you have your own little space, or maybe you're in a closet or in the hallway, right? Or the gym, or someplace else tucked in a corner in the school? I've been there, done that. Or are you expected to work with that child in the classroom? Or are you expected to consult with the teacher or the aide and not do direct service yourself? What is the model? Because that's going to impact on what expectations you, the team, and the families should expect from your therapy. You cannot get the same results if you are only doing consultation to teachers and aides as you could if you take that child into a treatment room and are treating them yourself. Okay? So you have to have some expectations. This also goes into service delivery models. How many days a week? How long are sessions? Are you expected to see groups of kids? Because you've got 20 million kids on your caseload, and you can only fit everybody in if you do pairs, or 2 or 3 at the same time. Okay? That's going to make a big difference. And then lastly, and this is really important, what is your personal training in this area? All right? A class like this is a good first step. I'm giving you a lot of basics, all right, to get you going. But if ultimately you're going to want to continue to take more courses, get more training, so that you can really understand your sensory integration theory and intervention strategies, and really have a much more solid handle. Doing practical hands-on classes is important as well, so that you get mentorship around what you're doing. I mentor clinicians who are experienced clinicians from all over the world around their intervention. We do Zoom calls and we do mentoring once a month. All right, so it's never too late. You're never too far along if your training is not in that area. Okay? The next thing you do is think about the goal of your intervention. And there are differences between clinical services and school-based services. So in a clinical service, my goal is going to be very more focused on the sensory integration foundations. I'm going to spend far less time actually working on specific skills, because I'm going to set the child up and I'll have mom work on shoe time. Okay? On the other hand, with school-based services, I may be able to do a little bit of foundational work, but my focus may be more on specific skill development that's needed in the schools. And this may also be different here in India and the models that you use for educational therapy services here versus what we do in the United States. So what I always tell people when I teach internationally is I'm going to give you the information I know, because I don't know your system, and you can take that information then and translate that into what your particular system is. Okay? So in the US, most of our school-based services are push-in services. They're meant to be very outcome-oriented, skill-based. So my goals for in the school might be that he'll stay in his designated space throughout morning meeting time, keeping his hands off of other children. All right, so what I'm thinking of in terms of functional goals, both of these are functional activities. It's very important that somebody not have defensive responses to stimuli. But I don't, as a clinical therapist, I don't have opportunities in everyday life to observe him. So I'm not going to make a goal about sitting in circle time, am I? Because I can't observe that. But in the classroom, in the school-based service, I can observe circle time. Does that make sense? Okay. Now, just a couple notes here about service delivery. These are some different models that we might use. First of all, we might have direct services that are in context. So this means that we're working one-on-one with the child in their classroom. All right? This is one of the ways that we will probably make some decent progress around praxis. The thing to keep in mind around praxis skills is that you can't really treat praxis effectively sitting in a chair, because praxis is about moving and interacting with the environment. I can improve fine motor praxis, but I'm not going to do a lot about whole body praxis. Okay? So if I'm only working in a classroom, unless I have the opportunity for that child to do some bigger body movement, okay, I need to be reasonable about my expectations about what I'm going to change. I might change some sensory processing, because I might be able to do some sensory activities. Am I going to change vestibular very much? Probably not a lot if I'm not moving, right? It's hard to do. So in this case, with direct services, I'm usually going to work one-on-one, maybe with a team member, and the activities I'm going to do are going to be specific kinds of activities. I might make changes to the environment to help change that. Now, I may do direct out-of-context services. If I'm lucky, this means in the clinic. It means I'm pulling the child out of the context. I'm going to do one-on-one. This might be in the school. It might be private or agency-based therapy services. Could be any number of other ancillary services above and beyond OT, okay? And my goal in that setting is really going to be to really get at those foundational abilities. All right. So one of the things I want to think about here is, thank you. One of the things I want to think about here is, what should we expect from praxis intervention? If we're really working on praxis, what should we expect as outcomes? First of all, we should see better organization of behavior, more regulated arousal state because they're better able to manage task demand, better self-regulation because I'm not going to get disorganized by my praxis activities, right? Better language and communication. If I can organize my body better, I'm probably going to be able to have better language and communication. better social interactions, obviously improved motor performance, better flexibility with routines and changes and transitions, coping skills should be better, and functional behaviors. Ultimately, I want better learning and better participation. All right? So those are the kinds of things I would be thinking about wanting to ultimately improve with my Praxis treatment. Okay. What kinds of interventions, thank you. What kinds of interventions can we use to improve Praxis or to address Praxis challenges? Because there's a lot of different ways to approach this problem. My favorite, my go-to, my preferred method is obviously sensory integration. Okay? I think AIRS SI is the best way. All right? My goals with AIRS SI is going to be to improve those sensory foundations. I'm going to improve the ability to adaptively respond to the environment, make those adaptive responses, complete daily living activities, and to participate effectively in functional activities. I mean, ultimately, that's what it's all about, right? Participation. Now, if I am working in the classroom, I need to be more skill-based focused. I may choose to use a model like the co-op. Are you familiar with co-op? A little? Okay, this is the cognitive orientation to daily occupational performance. This is a problem-solving model, okay, that teaches the problem-solving process. It's very task-oriented, okay, and it's about identifying specific skills that the child needs to learn and then working on developing strategies, problem-solving strategies to learn those skills and then ideally transfer to newer additional skills, okay? So we're really looking here, they use what's called the goal, plan, do, check model. This is all top-down. It's very cognitive. They do use some sensory motor strategies as part of that problem-solving process, but it's more about cueing, okay? So this can be a nice approach. What I have found the most helpful is to use this model in the context of my sensory integration therapy. I can use the cueing strategies for problem solving, for thinking about how to figure out problems in my SI sessions. So I'm getting all of the benefits of my SI sessions while I'm also working on the cognitive abilities at the same time. So I find that they're not mutually exclusive, okay? Now, one of the problems you will run into is what if you're working with a level 1 autistic child? This model is not going to work very well, is it? Now, so we have to think about which kind of intervention model is most appropriate for the particular client that we're working with. All right? Okay. He's still writing, so I'll let him write down. Okay? All right. Another thing that we might do is we might put into place accommodations and adaptations or sensory diets for our particular kids. This is an important point. Sensory diets are not just for modulation problems. Sensory diets can also be appropriate for praxis issues, okay? Now, our goals of this type of an accommodation, adaptation, or sensory diet program is going to be to overcome specific problem areas, all right, around praxis. If we're talking about a sensory diet for arousal and modulation, it's not necessarily specific skill-based. But for praxis, it's going to be around specific problems. Okay, so those are our three main choices for praxis intervention. Okay, I'm going to focus mostly on SI, but I'm going to give you some of other cognitive and sensory diet things. Talk a little bit about sensory diets at the end of the day. All right, the next thing we want to do, in general, if you're working in the schools, you need to think about maximizing activity participation, right? Isn't that what they want in school? They want that child to participate in the school-based activities. So we're looking here at, first of all, what is the child's individual preferences for sensory inputs to support them? Is this a child who needs a lot of movement? What did we see with the clip that we watched at the beginning? That child needed to stand in order to participate. Okay? So we may need to look at different ways of standing or sitting, being able to move around. Okay, look at everybody in here. Some people are leaning over, some people are sitting up. I need my tea to keep me going for the day. I'd be in bad shape, guys. I'm sorry. I know it says no food. You're not allowed to have your tea to keep you awake all day. All right? But I have to. So we all have individual sensory preferences, right? So we're going to keep an eye on that. Secondly, we need to think about what kinds of sensory and movement breaks are needed for that child to support their participation. Some of that may be to regulate arousal, but we're thinking praxis, right? What do we need for praxis? Maybe that child needs to bounce on a therapy ball because they need vestibular and proprioceptive inputs to give them adequate postural stability to be able to do handwriting. Does that make sense? So thinking about what kinds of sensory activities are needed to support their participation and their praxis engagement. Then think about instructional methods to support those praxis challenges. Okay, this kid has sequencing issues, right? He doesn't keep up with the sequences. What are we going to do to help him get the sequence of the day and the time management of the day? Well, maybe I need visual supports or schedules that are put up on the wall. This child has problems problem solving and organizing himself, and he has difficulties with ideation, so he doesn't know what's coming up. He can't infer what's coming up. So what might I need to do with him? I might need to preview. So I might need to say, okay, we're going to have break now, and when we come back from break, we're going to do math. And you need to get your math book out as soon as you sit down at your desk. I'm giving him the preview of the idea so that he knows what to do motorically when the time comes. Does that make sense? Okay. Does it make sense? Yeah, okay. Previewing is really important for us to have an idea. Okay. Written instructions. Maybe that previewing needs to be done in writing and not just told to the child. In addition, following verbal commands is hard. Sequencing is hard, right? So writing things out step by step that the child can follow might be helpful. Looking at specific kinds of activities to support the child. Maybe this child needs to play with therapy putty before he does his handwriting, because he needs to do that, get enough probe and tactile input to be able to hold his pencil to write effectively. Does that make sense? Okay. And then also, our kids take longer. And we need to build in enough time to complete activities. We need to figure out how much time it takes that child to complete something and allow them to have adequate time to complete what they're doing. That's probably one of the biggest accommodations we can make. Now, when we think about activity considerations, we need to think about how we're presenting information and the sequence of those specific tasks. And this gets into what is the child's best learning modality. Does this child learn best visually or auditorily? Now, can you guess what my preferred learning style is from the way I do my lectures? My preferred learning style is visual. Because what do? I put everything on the slides. Because when I'm in the audience listening, I want to read what the speaker is saying and have them just supplement it with a little bit of information to make it make more sense. But I want to be able to read what's up there. So I lecture in the same way. Okay? I lecture that way. I have everything out on the slides so that you can read it. I have a colleague of mine who, her slide deck is like, for an all-day course, is like 10 slides. And it's like each slide has got like a picture on it. And that's it. And she will talk with this picture up. I love her to bits, but I cannot stand to learn from her. Because I'm writing like a crazy person, trying to keep up, and by the time she said something, it's gone out of my head. Right? And there's nothing written down for me to go back to. And after I'm done at the end of the day, I'm like, what the HE double matchsticks did she talk about? And I've got no handouts to go look at. Right? So think about that from the perspective of our kiddos. You know, what is their best learning strategies and learning style? Do they need it written? Do they need it auditory? We also need to meet their sensory and motor needs. Okay, I need my sensory needs. Also, can you tell what one of my other motor needs are? I need to move, yeah, okay? I cannot stand behind a podium all day. Okay, I gotta move around. I like to demonstrate what we're talking about. Okay? How do you present materials? Okay, I'll give it to you. I probably talk way too much. I do tend to present in a very auditory manner, okay, but I give you the visual besides. So you need to also think about how much information is being presented. So you notice some of my slides, I only have bullet points, and then we talk about stuff. Other things that I think are important information, I put everything on the slide that I'm going to talk about. So that stuff that's important, you've got it in writing. Stuff that is more loosey-goosey, you get bullets. Okay? So we think about how to do it. I mostly try to have fun pictures on my slides. Not everyone, but I try to jazz it up. Also think about breaking down the task. What are the steps that are needed? What's the sequence to complete the given activity? So when I was organizing this course, for instance, I'm thinking about, okay, what structure do I want to use to present you with this information? What kind of structure do I need to use? And it's the same thing we have to figure out to help teachers know how to present information. And you notice what I have last? Time to complete. Okay? All right. Let's think about our little case study this morning. What challenges do you think our little guy, I'm calling him Peter here, but we're going to use our guy this morning. What challenges do you think he has in the classroom? Just in the little snippet. Sitting on the chair, staying in his seat in the classroom. Big problem. What else? Following instructions. Right. Teacher says, get out the book, get out the paper, right? Okay, what else is a problem? Handwriting. Yeah. Manipulation of materials, probably. We saw scissors. But do you think, how did he do with the beads and everything? Any kind of manipulation of any kind of objects. What if they're using those little cubes for math? Is he going to have a problem with those? Yeah, so we're going to see an issue with that. All right. How's he going to do in gym class? Probably not so good. How did he, you saw him with the ball, right? After a little bit, he's like got his face on the ground. He's falling down. He's getting overloaded. Okay, so he's not going to do well in gym class. All right. What kind of services would you provide for him? So think about your role. Think about this kiddo. What kind of services are going to work best for him? What might you do? What do you think, based on what we talked about? I'm sorry, nice and loud. Oh, the least restrictive. Restrictive. Okay. It's that, you guys have this, I find this with the Indian pronunciation. You have your own little flavor of it. It's like British pronunciation with a twist. So all of the accents are in the wrong spot for me. It's like, what are you saying? So I apologize. And my auditory discrimination is not very good. So I have a hard time understanding some of the words. So I apologize. It's my problem. So yes, the least restrictive environments is what we want in the school, right? So what do you think is least restrictive for him? Are we able to, do we need to do pull-out? Can we do work in the classroom? Consultation? What do you think? What do you think? Pull-out would probably be the best for this kid, at least some, right? Now, we might make some progress with one-on-one in the classroom as long as we can do some gross motor activity. Is consultation model and sensory diet alone going to be an effective model for him? No, not by itself. Do we want to do it as an adjunct? Yes, but not alone. Okay. Next thing you want to think about is what kinds of activities we can do to support him. So I want you to just start thinking about that, and we're going to talk about that next. Okay? All right. Next thing, intervention strategies. What have we got here? It's almost 4 o'clock. When do we have break? Let's see. We came back at 2:30. It's almost time for break. Perfect timing. Okay? Yeah, are we ready for break? Or what time did they have break down? Okay, thank you very much. She's going to check. I know that they have time. What time? What time are they having break? No break for the rest of the afternoon?
Right. Because when they come back and get over the...
Oh, wait, my watch is not right. I'm sorry. It's 4 o'clock. I only have an hour left.
4 o'clock. If you give the 15 minutes break, then
Okay, then we won't have time. Okay, I'll tell you what. Here's the deal. I've lost a half an hour in my day today. We may not get through everything. All right, but we also lost afternoon break. So stand up for a minute. We all need a stretch. Okay? Stand up. Let's do. Come on. Shake it out, shake it out, shake it out. Woo! There we go. Come on. That's it. Shake it out. There we go. And up. Let's get a little vestibular. Come on. Lean over. Let's get some vestibular input. There you go. Side to side. There we go. We got to re-regulate that arousal. Oh, my goodness. Okay. Is that a little bit better? Stop a minute. There we go. We can run. Check, 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 check. All right. Now we can all sit down. All right. Okay. Woo. I don't know. We'll go quick. All right. Praxis intervention. Yes, sir. Exactly. I know. I'm trying hard here, folks. I'm trying hard. I'm trying to be adaptive and flexible. Okay. We're having a good time. It's all good. All right. Thinking about organizing your thinking around intervention. All right? I like to use what I call the SAFE approach to praxis intervention. All right? SAFE stands for sensory, address the sensory needs. Shh. Adaptive responses. We want to elicit adaptive responses. We want to promote functional skill development. And we want to have an environment that is supportive of those skills. So that's how we're going to talk about treatment. Okay? All right. I'm going to go fast. All right. Core intervention principles for praxis. You just said it. Meaningful intensity of sensory input. You have to have sensory stimuli that is meaningful to that client. Remember, discrimination. These kids with praxis problems have sensory discrimination issues. Many of them need an intensity of input far and above what you or I might need. Okay? This can be one of the hardest things to get in the school setting. All right? Like you said, standing up and doing this little activity, for most of us, that's enough to kind of get us through the next hour or so, right? But there are going to be some people that's like, oh man, I really could have done that a lot longer. All right? Same with our kids. Number 2, praxis requires repetition in order to develop. You need to do things at least 5 times. So whatever those motor skills are that they're working on, we want to build in repetition of action. Okay? Next thing. Whatever activities we're working on have to be at the just right challenge. If the task demand is too hard, it is going to cause frustration. We're going to get those behaviors, all those things we've talked about. On the other hand, if it's way too easy, we often have lack of engagement. We want to start low. It is important that whatever you do with the child, you start at a level that they can already do it and be successful. It is much better to start with an activity that is too easy and then ramp it up quickly than to start with an activity that is too hard and have to backtrack. If you start with an activity that is too hard and the child can't do it, we're taught, oh, well, you adapt it down so they can be successful. But what have you already taught the child? Failure. You've taught them that I fail. All right? Even if you go back and you change it so they can succeed, their first experience was failure. So we always want their first experience to be success. Okay? Secondly, we'll talk more about this. Praxis requires movement through space. This means moving the body through different spatial planes of movement. Up, down. If that child is always upright, never does anything laying down, rolling over on his back, we're not going to get very far. So I encourage you to look at different ways of doing activities. And you can do this in a classroom. Kids can lay down on the ground and prop up on their elbows. They can sit back in a beanbag chair. They don't have to be sitting just upright at a desk. Okay? Change those body positions. They can read laying on their back on the ground. All right? That can be perfectly appropriate classroom behavior. We also want to think about adaptive responses. So if we're setting up accommodations, if we're setting up activities, we want that child to be able to successfully meet the demand of that task. Okay? And lastly is this idea of zone of proximal development. The zone of proximal development is the difference between what the child can do by themselves and what they are able to do with support. Okay? So when we're thinking about activities in the school, there's not always a lot of support, is there? Kids are expected to do things independently. So we need to think about this zone of performance and look at what are my expectations for the child to do this independently. Can I improve that independent participation and performance with different supports? Maybe those supports are not people supports, maybe they're environment supports, maybe they're task supports, but can I increase that zone of performance with some kind of support? These are core principles for addressing praxis. Yes. Yeah, so this might be something, and I'm going to show you some more, but it might be something like visual schedules. Maybe I put a visual schedule on the child's desk with something that they covered up, so as each task is done, he covers it up. That may help that child sequence expectations independently without the teacher having to be on top of him all the time. Okay? That's the kind of thing we're talking about. All right, let's talk about intervention for sensory foundations. And you know what? I am going to zip through this because I think from a sensory perspective, this is stuff that you generally will know, and since we're short of time, okay? Because I want to spend more time on the actual practic things. All right? Real quick, intervention things to think about: tactile, probe, vestibular. These are the foundations each sensory system addresses. To regulate arousal, you have to address the environment, and you need good, intense input for regulation. This might mean weighted vests, might mean brushing, might mean being able to play in the beans. Rhythmic movements. Have opportunities for rhythmic movements. might mean therapy ball seats. Heavy work proprioception, pushing things, carrying things. In the school system, we often have kids carry books from one place to another or push a heavy cart to get prop. Now, there are specific programs that can be used to help with this area. You're probably familiar with these. The ALERT program, the Zones of Regulation, and the CERTS program are activities. Now, intervention strategies for adaptive responses in Praxis. There are 4 general intervention strategies. First of all, you have to identify what bottom-up and top-down strategies are appropriate for the type of intervention model you're using. We want to make sure that we're structuring the environment, okay? And we're selecting activities that have the right sensory inputs, and we're grading them for the just right challenge. Now, I will tell you some of the intervention pieces are not written out in your notes. I realize that. If you would like to take pictures of the slides, please do feel free. I just ask that, I'm just trying to think. There's a couple of them with children that I don't think you can have the photos up, but I'll let you know if that's the case. Okay? Otherwise, if you don't want to write things down, feel free to take a snapshot. Okay? Okay. For Praxis, if you don't forget anything else, these next couple of strategies are the important things. First of all, repetition. You need to repeat things at least 5 times to encode them as motor and memories, to have them available for later Praxis activity. So it's important that you build in this repetition in whatever motor activities you're having the child do. So if you're doing handwriting, if you're stacking blocks, you want to have at least 5 repetitions. Another important thing is to do what I call close the loop. It's important that activities have a beginning, a middle, and an end, and that the child be a part of the process of completing the activity. That means helping clean up. All right? So you want them to be a part of the cleanup, put away process at the level that's appropriate for their abilities. So for an autistic child, that might mean putting 1 book on a shelf. For a child who's 12 with learning issues, that might mean packing everything up and putting it away. Okay? But they need to end that activity. We never want activities to just randomly flow from one thing to the next. Like, for instance, if I said, okay, we're always going to close the loop, and I just walked away, how would you feel? You'd be like, what? Right? Because we have to end the course, don't we? I'm going to say, thank you, at the end of the course. Hope you enjoyed the class. I'm going to end it. I don't just drop it in the middle of the activity. So everything that they do should have a clear ending. All right? That's real important for Praxis development. Now, for specific aspects of Praxis, ideation. A lot of different things to do with ideation. First of all, these kids don't pick up on perceptual cues. So you need to increase the salience of the cues. That might mean using brighter colors, drawing boxes around things to draw the attention to what's important about the assignment. Maybe you highlight key points in a homework assignment. Okay? Another really important strategy is asking questions. If you are telling the child what to do all the time, they are never coming up with their own idea. So you need to frame what you want them to do as a question. It can be tone of voice. It can be more. All right. Climb up. But you make it a question. Then it becomes the child's idea to make the response. Okay? We also want to work on doing different variations of objects, object use, and actions. We also want to help them develop better representational memory. One of the best ways to do this is by drawing pictures. So what you might want to do is have the teacher have the child draw a little picture of different things that are happening throughout the day. That helps the kids create a mental image of the task that they're doing or the parts of the task and to put them down on paper. Okay? All right. Another thing you can do is to give them mental images by using visual cues that they're familiar with. So things like you're climbing like a monkey, or you're sitting like standing like a soldier. All right, things that they're familiar with. We also want to model your thinking. These kids don't know how to approach things, how to come up with ideas. So you might model it and be like, wow, if I wanted to find out where my book was, I might look under my desk. Oops, it's not under the desk. Where else could that book be? All right, maybe it's on the shelf. So I'm going to talk through that process of figuring things out. And I'm going to engage the child as well in different kinds of activities that are going to build their action and object affordance knowledge. So for instance, I'm going to have them do activities with different objects in different ways so they can use different actions on it. So for instance, instead of always using the same pair of scissors, maybe I use different kinds of scissors. So they have to learn how to cut using different kinds of scissors. All right? So here's an example. I love Calvin and Hobbes. This is a great example of affordances. He's going whap, whap, whack. Mom says, Calvin, what are you doing to the coffee table? And he says, is this some sort of trick question or what? So what is he doing? He's recognized that the coffee table affords pounding nails into. All right. A few more ideas for ideation. I gave you a lot of these because I think this is one of the hardest things for people to know what to do. Pictures, lists, picture schedules. These are very helpful in establishing those visuals, those representations. Rehearsing and revisiting. So going over what you just did. All right, everybody, we just finished writing our spelling words, and now we're going to get ready to do our math problems. Math is coming up next. So we just reminded him what we just did. Okay? So we're putting into words actions that have just happened. We also can use verbal mnemonics to help them. We all know the bunny. You all know the bunny to tie your shoes, right? And then that idea of mental imagery, using examples of mental images. So remember, we're going to do this like, I don't know. I'm used to using examples in the clinic. I'm trying to think of a school one. Can you stack up your books like a nice tower? Okay, that kind of thing. Another important thing is these kids with ideational issues are very rigid. So we need to break out that rigidity. And so what we want to do is be goofy and absurd. All right? Humor really helps. Make fun of things. Use those representational language. Okay? And they aren't going to like it. But we're going to say, well, I have to do it. You don't have to like it. But I'm going to do it anyways. Word games, rhyming games. For us, it would be things like, hey, get back, Jack. See you later, alligator. Right? So whatever works for you guys. Bridging techniques are things where we are commenting on what's going on now and relating it to things that we've done in the past. Oh, okay, everybody. Do you remember? We're going to have a break. Do you remember what we did last break? What did we do last break? Handshakes. There you go. Okay, we're going to do that now. Everybody, can you stand up? I asked you a question. Do you see? So it's a matter of how we approach the task and how we use language. So you may need to do some education of the teachers because it's going to be hard. And then comparing and describing, very much the same. Oh, this activity, we're going to do math problems today. And we're going to do, our math today is going to be like the problems that we did yesterday. We're going to put this up here, and we're going to put this here in the same place that we did before. So that you're making very explicit to them that this activity that they're doing now, they know what to do with. All right? We're going to encourage exploration. Another thing we can do if we're working in gross motor, whole body activities is what we call creative obstruction. This is where the child always does things the same way. They like to go this path, and we throw something in the way. So in this case, maybe the kids always like to do an assignment a particular way. And you're going to be like, okay, today is backwards day. Everybody needs to do things backwards. We cannot do it the way we always did it. We have to do it a different way. So we're setting up an expectation or a roadblock to them being able to do things the same old way. We also want to use familiar themes, using frameworks that are familiar. So for instance, if they're young kids and they like Thomas the Tank Engine, they know what the world of Thomas the Tank Engine is like, and so we can frame what we want them to do within that world. And I think those are all the same. All right? So that's our ideation. Now, for motor planning, there are 5 major strategies. First of all, we want to try and be playful. Motor planning is developed best in play. You can still play in the classroom. We can have fun in the classroom, right? Okay? So you're going to remember a lot more if I'm teasing you, if we're joking, if we're laughing and having a little bit of fun. Rather than if I just stood back here behind my little stadium and I talked to you like this all day long, you're not going to remember very much of what we talked about, are we? No. So we want to be playful and enjoyable. We also want to vary things. Okay? We don't want the same old schedule every day. We want a little bit of variation so that there has to be some adaptability. We want that activities that are presented to be the just right challenge. That comes up a lot. We want to build adaptive responses. That will happen if the activity is at the just right level. Okay? And it's important that we give precision feedback. Remember, our kids don't get feedback from their bodies. What that means is no more good job, good work. It has to be, Johnny, I love how you wrote your name on your paper. You got it right on the line. Or, oh, Johnny, you wrote your name so nicely, but I see that the last 2 letters are a little high. Next time, do you think you can remember to put them on the line? Precise feedback about what worked, what didn't work, what's a problem, and what they did right and what they didn't do right. Okay? All right. Here's an example. I'm going to show you this video. This is my friend Wilma. And she is in a preschool classroom, and she is doing a group activity for the whole class. And this is important because depending on the age of the children, we don't have to do intervention just for our kid. All children benefit from these activities. They should be things that should be part of everyday activity. So this is just an example of this gross motor activity. And what she's trying to do here is to promote problem solving. Okay? And we're going to look at how she went about doing this. Why do I have no sound? Have no sound. Can you turn the volume up on this? All right, I'm going to stop this because you really need to hear what's being said. Can we get the audio? It was working before. Why is it not working now?
Oh, phone book.
Okay, we don't have time for this not to be working. Okay, I'll tell you what, we're going to do it like this. That's up. This is not, I don't understand why this is not working. Okay. So the idea here is this is a scooter board. And you notice she's got it upside down. And the kids have been told that they need to work together. The two boys need to work together to do this activity where they can get the scooter board. But what is she doing? She's standing on the scooter, it's upside down, and they also need the rope. And she's got the rope on her. So what she's done, and she's just standing there. So they have to figure out that, wait a minute, you're on the scooter. And then they have to tell her, well, you need to get off of the scooter. And also they eventually say, well, you need to get off. And she steps up, oh, okay, here? And she like moves on the scooter. No, off of the scooter, over here. And so they tell her, you need to stand here. Then she's still standing there and she's like, well, now what? And they're like, well, we need the rope. She's like, okay. And they're like, you've got the rope. We need the rope back. She's like, oh, well, okay. And they reach up and take the rope. Okay? So she provides these obstructions that make them have to do problem solving. Okay? Is this working? Yeah, there's sound on the audio. What is going on here? Is that in the wrong one? Okay. I really don't have time for this. Okay, so now what's going on here is this little boy is getting frustrated. All right? He's getting frustrated. Did you just stop that again? stopping my videos. Okay. So now the two boys, the teacher fixes the rope to the scooter, but the two boys now are having to talk to each other to figure out what to do next. And it's like, who's going to be the driver and who's going to be the passenger? And this little boy in the front, he says, I'll be the driver. Okay, well, what do we do next? So you can see here that the emphasis on this activity is not about riding on the scooter. Okay, the emphasis on this activity is about the kids figuring out how to ride on the scooter. Okay? So it's about them problem solving. So now the next thing here is they're figuring out what they're going to do next. And are they going to jump down? Wilma told them they had to jump down together. And how are they going to jump down together? Now they're calling back and forth to each other, and they have to roll the ball back and forth between them. So there's all of this problem solving happening in the context of this activity. So in a classroom, dyads, small groups can work very well for developing some of these practicabilities. Okay? Does that help you to see that? All right. What is this? All right. Let's move on then. Okay. All right. Why is my PowerPoint uploading? Where's it? What is it doing? Why is my PowerPoint uploading somewhere? Why is this uploading?
Like it's swinging, like wondering it's swinging.
It's syncing. Okay. All right. That's you connected me to the internet. Okay.
It disconnected? No.
No, I need to close this. Okay. All right. Okay. Next thing. That gives you a little bit idea what some of that ideation might look like in a classroom. Now, intervention for motor planning. 3 things I talk a lot about are getting back to basics. That means working in basic developmental motor patterns. I like to have kids do a lot of log rolling, crawling, combat crawling, kneel walking, okay, instead of just sitting or walking. We want to get back to these basic patterns. You can do this in a classroom. Maybe everybody has to kneel walk from one spot to the other. Maybe everybody has to crawl for an activity. Teachers can mix this up. This can be a good way to move it. Getting your head down. What I was talking before about getting out of an upright position and changing body positions. All right? And then, what's the plan? Have children with motor planning problems need to talk through what's going on. Not just what's coming up. If I am standing here and I tell you, okay, we're going to do this, and then we're going to do that, we're going to do that, we're going to do that. That's executive planning. I'm working on executive functioning because I'm planning abstractly into the future. On the other hand, if I say, oh, I just moved the mouse on my screen and hit the key to change the slide. and I need to hit the key again to advance the slide. That's praxis, because it's the immediate what I just did and what I'm going to do next. Okay? So teachers can, or you as the therapist, can help the child talk about what they just did. Oh, what did you just do? Oh, we just pulled the scooter. We just put the rope on the scooter. Okay, does that make sense? So we want to do this kind of rehearsal. Now, strategies. You need sensory input. So lots of tactile and proprioceptive input. This can be massagers, bean bins. We may use vestibular and proprioceptive inputs for body awareness in space. We also want to structure that environment to the just right challenge. So that might mean limiting the number of items on a page for math. It might mean putting color coding on the child's cubby, or putting bins in the child's cubby to help them organize their cubby. All right? If I'm doing activities like this, I need to make sure that the child can, I'm asking them to balance on a surface they can actually balance on. We want to work in different spatial planes, especially diagonals, okay, if possible. So have kids climbing up slides, all right, using those diagonals if you're able to do movement. Gross motor construction is very helpful. So these can be things that could be done in the classroom. Cardboard boxes, cardboard bricks. Kids can build things related to whatever the particular academic activity might be. And regardless of what the activity is, the child should be involved in setting up and moving and taking down equipment. Now, we already talked about beginning, middle, and end. We also want the child to help set things up, and we want to do that 5 times repetition. Providing that precise feedback in what they've done is important. I want to make a point here. We're very often, especially in the schools, about giving kids feedback about their impact on the environment or other people. We're often saying, look, you did that to Susie. Well, that's not helpful if Johnny doesn't know that he actually knocked something over in the first place. So try to provide feedback that is about the child's actions themselves first, before you worry about giving them feedback about what they did to others or how what they did impacted other people. Okay? Another really important thing, because sequencing is hard for these kids, one of the things we want to do is use numbers. Number things. Okay? So whatever is the next step, it's number 1, number 2, number 3. And you want to use that language. If you use first, second, and third, or I know all the speech therapists love first this, then that. That is abstract. Our kids like concrete. Numbers are concrete. I tell you, you will get far better performance by using numbers. Step number 1 is X. Step number 2 is X. Okay? Use those numbers. It will really help kids get the sequences. And this can be done in any of your activities in the classroom. Okay. I want to just show you part of this video, okay, so that you can see what motor planning might look like in the classroom. This is actually about a 20-minute video, and we don't have time for that, but I do want to show you just a little bit at the beginning. Now, this isn't a clinic, but I'll show you just a little bit of it. I do have some school-based treatment activities. Sorry, I'm really disorganized here. I apologize. I'm very conscious of the time, so now I'm feeling really, see, my arousal level went up and my organization is going down. And then the audio didn't work. So let's see. This works. And this doesn't work either. Okay. All right. So I will just tell you what's happening here. This is this child's second session. She was here the week before. And I asked her, what do you want to do today? She said, I want to play it. She says, I want to play Sharky. Like a shark in the water. This was a game we played the week before. And so she is actually telling me now how to play the game. She's on a boat. She's telling me, you're going to be the shark. Do you notice how hard her motor planning is getting on the swing? And even getting herself organized to pump the swing is difficult. So I told her I had to get my shark teeth, which is a brush. Now I want you to notice here, she is bashing into these tires, and she's totally oblivious. Totally oblivious. Now I'm going to have the shark attack her and brush her legs because I want to give her some deep touch pressure to help build her body scheme. I'm giving her some unexpected movement that she has to adapt to. The shark is attacking her. She's getting her deep pressure. She's like, okay. Now look at how much easier she gets on the swing, but she's turned around. So that little bit of vestibular and proprioceptive input really made a big difference in her motor planning. Now she's telling me, oh, there's a big storm coming, no sharks in the water, I'm going to escape away. So there's a storyline that we use with this. Still hitting the tire and not being aware of what's going on. Okay, so she's getting some more input here. And I'm just going to move this farther. That was a little bit too much for her. She went and hid behind the pillows. And she stays back here for a couple of minutes. But I want you to see what she looks like when she comes out. So she takes a little while to reorganize. Now watch. She comes back, immediately recognizes that she's turned around.
Uh-oh, see you later, Sharky. Uh-oh. Oh, no, here comes the shark after your boat.
And look at how much better she's able to pump the swing. So repetitious movement, deep tactile input, some vestibular, repeating the activity. She's now like the fourth or fifth time on the swing. Now she recognizes she's hitting the tire. And she now is going to throw herself off into the pillows, and she times it. Okay? So can you see the big change in a very short period of time there? Okay. All right. Next thing then is adaptive responses. And adaptive responses are the ability to make effective responses to environmental demands. And they're really the outcomes of our praxis. You know what? I'm just going to leave this. These are the different levels of adaptive responses. Okay? So if you want to take some snaps of this, these are our different levels of adaptive responses. Okay? This is the second. So there are 7, which range from just being able to take in and process sensory input to being able to do complicated activities. All right. I want to move on then to bilateral integration, projected action sequences. Core strategies for this area include using rhythm, vestibular, visual and proprioceptive inputs, moving through space, and timing of activities. So with the clip that you just saw, that child was working on motor planning, but she also was working on bilateral motor skills and projected action sequences. Okay, she was getting the rhythm, the vestibular, and the sequencing. So things that you can do, this is just a cute little clip. Here's an example of an idea for a treatment activity. So this little guy liked American Ninja, the TV show, or Ninja Warrior. So you can set up very simple activities out on the playground maybe for the kids to help work on some of those sequencing skills. Get that head down, right? Change body position. And this is in the context of fun. He's being a ninja warrior. Okay? All right. We talked about sequencing, reinforcing beginning, middle, and end, numbering things. A couple other considerations for bilateral motor coordination. You'll want to take a snap of this. These are guidelines when you're thinking about complexity of activities. Symmetrical activities are going to be easier than asymmetrical ones. Upper limbs are going to be easier than lowers. So it's going to be easier to do sit-down, tabletop, bilateral activities than whole body. Here are a few examples of some bilateral activities. This is what we call sock, no sock, stride jumps. Child takes his sock off his foot, puts it on his hand so he can alternate. Rotation activities where kids sit back to back. This is on a swing, but you could do the same kind of activity sitting in chairs. And they have to turn around, pass something to the child behind them. This is in a kneeling position. The child is batting at a suspended balloon. She happens to be on an air pillow here, but you could also do something like this with another child batting a balloon back and forth, for instance, or a little badminton thing or something. All right, for projected action sequences, these are the parameters. We're looking at slow. The slower you move, the easier it will be. Fast movements require a lot more feed forward. They're harder. And you're going to work on spatial skills when the child is moving. Then we have timing, okay? And there's different kinds of timing activities that you can do games with the kids. This involves coinciding yourself with objects and others. So in other words, being in the right place at the right time to kick the ball. Staying in unison, walking down the hall together. Intercepting, moving here to get the ball that's been rolled over. And avoiding. This is like dodgeball. Okay? Avoid the ball. Okay, oops. So this is a nice activity I wanted to show you. That's something you can do in class. This is a drumming
set of sticks.
It's a drumming program, but this kind of thing can be useful. It really works on imitation, sequencing, bilateral coordination,
not only
rhythm,
work all of their body parts,
right?
but they also get to work
Works
both
on
their
a lot
left
of those
and their
skills.
right brains. Switch directions, go the other way.
Drumming,
So this is on YouTube. You can find this video on YouTube.
Here we go.
Get the narration
Freeze,
that
close
goes
this
with it
ball. Drum
that we
roll.
can't hear.
Yalla. Dancing. Show me your moves. Drum roll.
drumming, usually you just
there we go.
hit on something, but this
Now it's
this
working.
helps you with
You get
your
alternating
reflexes and
and
things that when
symmetrical
you know
movements.
when to hit it and when to use your glutes or any other different body muscle. And we're also like exercising on the ball, like going down.
Good. Keep your body straight. Stand tall.
And then going up.
And those heart rates up there. What's innovative about it's creative for the kids. They can get together in small groups if they want, create their own movement patterns, and it's a good way to do a new rhythms, exploration.
It just gets you all relaxed and it gets you all comfortable, and then it's easier to work.
Lean.
My legs weren't that big, but now my legs are going crazy. I've been getting stronger every time.
Superman. Opposite arm, opposite leg.
We normally go on and off of everything. We could switch from soccer to football or something. But I think this is better because we all know how to do this.
Tighten, lift. Tighten, lift. How about the heart rates? Are they up there? What makes it fun? Music, movement, the sticks, of course.
If I've had any problems,
I'm going to stop there. This is a couple minutes long. But I think I wanted to show that to you as a really nice school-based activity that works on so many aspects of Praxis. Scooter boards are always great to use to work on Praxis skills if you have that ability. This is a game called Capture the Flag. The kids are playing this in a clinic setting, but these kinds of games are also great to play out on the playground to work on Praxis. Here's an example of using inclines, hopscotch, scooter board. In this case, he's taking clothespins and putting them on a rope. Okay, next thing I wanted to show you then, this is some treatment that's happening in a school setting. It's one-on-one or one-on-two, and the therapist is actually working in a corner of the library in the school. Okay. Where is my mouse? So she has some simple equipment available. This is an inner tube and a therapy ball, a little stretchy rope.
Okay, good. Excellent. Great. Now what do we do? What's the next
Scooter
step?
board.
Okay.
So if you're able to do pull-out services, do some direct therapy, this is a way it can be done.
All right, remember you got to use your hands. Stay on the scooter board. Use your hands to move you. All right? Use your hands. Good. All right. Don't let the shark get it. All right. Whoa. Yay. All right. You got it.
Whoa! Oh no! Shark, get it! Yay! Shark, get it! All right. Go, Theo. Good job. All right. All the way back to the beginning, right?
I'm going to move on to the next one.
Where do we have to go to do it? Back here? What? Well, no, we're going to do it in the hall, remember? Let's go this way. Okay. You're probably going to have to stand behind me.
Go.
All right, you ready?
Yep.
Okay, here it comes. Whoa! Whoa!
And I think some of these activities could even be
still first in the
adapted
middle and then
for
hit it.
use in the classroom
All right.
for different
Good.
different activities. On here, they do this for a little bit. Now here she's got 2 kids.
Feet on the floor when it try to keep your feet on the floor, okay?
So using the therapy ball to get vestibular input in a classroom or school setting. The stretchy ropes are bicycle inner tube tires. They give really good proprioception.
Okay, I got you. Don't fall backwards.
It's pretty much the same. Okay. So I'll stop there. All right. So hopefully that gives you just a little snippet of what it might look like actually in a school doing some of these activities if we have the opportunity to do some pull-out. Okay. Functional activities. We can promote sequencing, time management with various timers and planners. Also important to look at metacognitive strategies, using those cognitive skills like predicting and planning and monitoring what they're doing, reflecting on what happened, and problem solving. Using schedules, timers to organize, some examples, visual schedules. Modifying the tasks where we can simplify the presentation of the activity, break down the steps. Keeping in mind fewer is better for most of our kids and having more time to do things. All right, and then looking at a supportive environment for accommodations and adaptations. So these are key strategies for home and school. So here's some tools to meet space demands. Thinking about desk and room arrangements, like this is a really bad classroom for our kids, right? Crazy. Everything's out in the open. We might want to look at helping teachers use closed-in storage solutions, using different seating options, room spaces where it's closed in, where kids can regroup. Here are some other accommodations, and these things are in your handouts. Other activities that can be done, you can do a lot of gross motor activities as whole classrooms. Brain gym activities are fabulous for that. Stick kids and tools for students and teachers are also programs that give good activities that you can develop for the whole classroom. These are some examples there. School Moves is another program you might be aware of that has great in-class movement-based activities. I also like these little move-about activity cards as ways to provide activities for the kids. The Out of Sync Child Has Fun has great movement activities, especially for young children. Music is also helpful. These CDs by Genevieve Jerub are great to incorporate movement activities for the whole class. Okay, I got like 5 minutes. So the last thing is sensory diets. And I want to just point out here that sensory diet programs can improve sensory discrimination for Praxis activities, and they can also accommodate when there are problems, okay? We can use them to help kids in a specific environment as a direct service or an adjunct service or as a transition service. So you need to kind of think about why you're doing them and when. There are limitations. Most sensory diet programs are short-lasting. They're not meant to make long-lasting changes. They're meant to help performance in a specific setting. Okay? There are differences between sensory diets and accommodations. Sensory diets are things that the individual does themselves, whereas accommodations are things that other people put into place. Now, when you put together a sensory diet, you need to develop a menu of activities, instruct the caregivers or teachers on what to do, write it out. You have to write out the sensory diet and then implement it and monitor it for change. There are 4 major components. You need to have regularly scheduled activities, environmental accommodations, sensory snacks, and supportive leisure activities. Okay, for accommodations, we can accommodate space. That might be where the child sits, whether they have cube cubbies, might be interactions, how you approach or talk to kids. We talked a lot about interaction styles to support our kids with Praxis issues, asking the questions, giving feedback, that kind of thing. Addressing the kids' sensory needs, and then looking at whether or not we need specialized equipment like slant boards, pencil grips. Do we need to modify papers? Also look at regularly scheduled activities. These could be group activities like the whole class doing brain gym. It could be individual activities like sensory breaks. And we also need to think about when those activities are going to happen during the school day. All right. When Praxis all comes together, we enable adaptive interaction with the physical world. All right? And thank you. I'm sorry we had to kind of rush through the part everybody wanted the most, but I lost a half an hour of my day. We would have had more time to spend on that if we hadn't have been running so late.